Well, good afternoon, everybody. My name is Kevin Murray. I'm the Executive Director of the Program on Human Rights in the Global Economy. For those of you who don't know it, FERGI is a 6-year-old human rights program here at Northeastern School of Law. And the focus of its mission is to increase the human rights content of the legal education here at Northeastern and beyond, and also to increase the connection between the research and other activities here at the law school and human rights advocacy and other activities outside of the law school. So we're very pleased to have you here this afternoon. Thank you for making the effort to join us. I have the privilege of moderating this first panel of our annual 2012 FERGI Human Rights Institute. The title of this institute is Human Rights and the Social Determinants of Health. And I think you'll see that we've gathered people that are going to be able to speak to this topic from a number of different perspectives. This first panel, we have 4 distinguished speakers with us. Each of them will speak for a few minutes in sequence, and then we'll have an opportunity for questions and answers and discussion after that. I'll take a moment now and just introduce our 4 speakers, and then they'll speak in sequence. First of all, directly on my right is George Annis. George is the William Fairfield Warren Distinguished Professor and Chair of the Department of Health Law, Bioethics, and Human Rights of Boston University School of Public Health. He's also a professor of the BU School of Medicine and at the School of Law. Tried to say that quickly a couple times. He is the co-founder of Global Lawyers and Physicians, a transnational professional association of lawyers and physicians working together to promote human rights and health. He graduated from Harvard College, Harvard Law School, Harvard School of Public Health. How did you ever end up at BU? On this side. Harvard School of Public Health, where he was... Sorry, the dean was... There he is. Not on my calendar, but that's good. After graduating from law school, he clerked for Justice John V. Spalding of the Massachusetts Supreme Judicial Court, and he came to BU in 1972 as the director of the Center for Law and Health Sciences at the law school. Next to George, Patricia Illingworth is an associate professor in the Department of Philosophy and Religion in the College of Business Administration, as well as a lecturer in law at Northeastern University School of Law. Professor Illingworth has expertise in both philosophy and law. She teaches courses in global justice, medical and business ethics, bioethics, health policy, and law. She has served on the Human Rights Committee of the Massachusetts Mental Health Center and the Ethics Committee of Mount Auburn Hospital, both affiliated with Harvard Medical School. Professor Illingworth has written 2 books, AIDS and the Good Society, and Trusting Medicine, The Ethics of Managed Care. She's also published widely in scholarly journals on professional ethics, the ethics of managed care, and other issues that overlap business and medical ethics. She's held fellowships at both Harvard Medical School and Harvard Law School. Professor Illingworth has been admitted to the Massachusetts Bar. Most recently, her research is on ethics, philanthropy, and charitable tax law. Ana Sofia Charvel Orozco is a practicing attorney and a professor of law and science at the Autonomous Mexican Institute of Technology in Mexico City. She received her law degree from the ITAM in 1996 and a master's in the history of Mexican law from the UNAM in Mexico City in 2001. She's published widely on the relationship between healthcare and law in Mexico, including articles in Spanish entitled Law and Health in Mexico, Proposals for an Efficient Relationship, published in the Mexican equivalent of the AMA Journal, and The Right to Health as a Social Right, published in the Law Journal of her university, the ITAM. She's currently a candidate for a Doctor of Law at the Pan American University. And finally, down at the end of the table here, certainly not least, Anya Rudiger is Program Director at the National Economic and Social Rights Initiative. Anya works with grassroots groups and coalitions to develop human rights strategies and tools to advance social and economic justice, particularly in the areas of healthcare reform and budget revenue policies. She's an expert on human rights and equality with extensive experience at integrating a rights-based approach to policymaking at local, national, and international levels. Previously, Anya carried out consultancies for government and non-governmental organizations, led the research department at the British Refugee Council in London, and managed the UK Secretariat of the European Monitoring Centre on Racism and Xenophobia. Anya received her PhD in political science from the University of Kiel in Germany. Thanks all four of you for joining us today. Having introduced everybody, I will now introduce Dean Jeremy Paul of Northeastern School of Law to welcome all of you.
Well, thank you, Kevin. I can see I'm playing in a fast crowd here. Everything is right on time. It is a privilege, actually, to be here to welcome you to the. Did you give them the title already before I got here? Well, hers give it to again. That's all right. But the idea of putting together an institute on the human rights and the social determinants of health reminds me of the way in which a lot of people look at doctors and sort of feel jealous. It's like the old story about the mother whose son or daughter is awarded the Nobel Prize in literature, and she's sitting in the crowd, and she's not paying much attention, and one of the people sitting next to her taps on the shoulder and she says, "Well, my other son is a doctor." But what I particularly like about this event is that it illustrates the way in which actually doctors and people who work on public policy working together can have an enormous impact on individual health and on saving lives. I pulled out a column from Nicholas Kristof attempting to identify for him the three most important advances in healthcare in his lifetime, and he identified them as the cigarette tax, seat belts and airbags, and the ban on lead and gasoline and paint. So for all of you who are lawyers or public policy people out there, we too can have an impact on public health. So without further ado, let me say thank you to the Program on Human Rights and the Global Economy and the program which is sponsoring this event in collaboration with the Health Law and Policy Program here at Northeastern. Let me say thank you to the four faculty directors of the Program on Human Rights and Global Economy, which we call FERGI, right? I knew I was at the right law school when there was a public policy institute that was named after a singer from the Black Eyed Peas. So they are Dan Danielson, Martha Davis, Lucy Williams, and Margaret Wu. And let me also say thank you to Hope Lewis as one of the co-founders of this, and Kevin to you as executive director, and also to Wendy Parmet, who is the faculty director of the program on health law and policy at the law school. Thanks also to the Ford Foundation, which I know has been a generous sponsor of the FERGI program. This is the third such institute that FERGI has put on. The last one was on framing and human rights last year, and the one before that in 2010 was about economic, cultural, and social rights for immigrants, sort of called Beyond Security. So I think it's a terrific thing for the law school to be sponsoring, and I'm delighted to have a chance to be here and a chance to welcome everyone. So I hope you all enjoy, and I'll see you soon. Thanks. Last but not least, let me introduce Martha Davis, who will also welcome you. She's, as I said before, one of the co-founders, co-directors of FERGI. She's a professor of law here at Northeastern. Her research focuses on domestic implementation of human rights, and she's the author of many articles on human rights, women's rights, and welfare. She's the co-editor of Bringing Human Rights Home and author of the prize-winning book, Brutal Need, Lawyers in the Welfare Rights Movement. Prior to joining the faculty at Northeastern, she was vice president and legal director of the Now Legal Defense and Education Fund in New York, and she's also the chair of the board of directors of the National Economic and Social Rights Initiative. I can also say she's one of the most efficient and well-organized people I've had a chance to work with. So, Martha.
So thank you very much, and I'll try to set the stage, then we'll hear from the panelists who have already been introduced. So I want to, there'll be more thank yous later, but I want to join Dean Paul in thanking Wendy and Kevin and Sasha and others who you all have dealt with in registering for this event, and we'll have more formal thank yous later. As Dean Paul indicated, Fergie's role has been to serve as a bridge between scholars and activists and to bring to bear interdisciplinary approaches to addressing public policy issues. And there are many university-based human rights programs in the United States, but not very many that focus on economic, social, and cultural rights as we do. And it gives us a unique perspective on many of the debates in the United States. So, for example, during this election year, there's so much talk about Medicaid, for example. Today's topic, health, food insecurity, housing, all of those are issues that looked at from an economic and social rights perspective become it's a very illuminating way to look at these issues. In discussions of health in the U.S., the focus is often on the mechanics of the healthcare system itself. But public health specialists know that other factors, that is the social determinants of health, may play an even bigger role in population health. These determinants include nutritious food, early education, secure housing, clean water, adequate sanitation, decent work, and universal social protection. Universal and accessible health care is one of these factors, but only one. And we know that the U.S. track record on many of these social determinants of health is not as high and not as good a track record as we would hope. For example, UNICEF recently reported that the U.S. ranks second among developed countries, right behind first place Romania, in relative child poverty. Food insecurity in the U.S. is close to record highs, food insecurity rather. Access to quality early education is uneven at best, with few states offering universal access. And I could go on. But I think the point is that these data points help us to understand why health outcomes in the U.S. do not fall in line and improve as we spend more and more money on the healthcare system. In the U.S., legal advocacy concerning economic and social rights such as food, housing, education, water, sanitation, and work has often been frustrated by our federal constitution, which grants rights to due process and equality, but not to a basic standard of living, not to basic food, not to basic housing. And as you'll hear from some of the speakers today, domestic advocates in the U.S. are increasingly turning to international human rights frameworks and mechanisms to press both the federal and state governments on a broad range of economic and social rights. Now, you might have noticed that economic and social human rights sound a lot like the factors identified as the social determinants of health: housing, poverty, food, education. And it's our hope that with today's institute that we'll begin to make some concrete connections between these two conversations in the public health community and the legal community that have been happening somewhat at arm's length, and that will fully explore the scope of social determinants of health, but also that some light bulbs will go off in this room about how we can pair these concepts to create more powerful advocacy tools for health and human rights in the U.S. So with that, I'll turn it back to Kevin. Thank you.
Thank you. Well, like you, I was so anxious to hear the speakers we have today that I couldn't even wait for the dean to get here to welcome you all, but that worked out. Thank you. I also want to remind everyone that Fergie in sponsoring these always requires, number one, the support of the law school in general, and always works in collaborations with other programs of the law school. And I think it's important to note that this one certainly could not have even begun to take place without the active collaboration in the design and organizing and presentation of the program of the law school's health law and policy program. So I want to recognize and appreciate that collaboration before we begin. Now, I'm sure you can all remember the long introductions I gave to each of our speakers some time ago. So without further ado, George Ennis from Boston University, please.
Thank you. I want to especially thank Wendy Parmet for inviting me to speak today. I'm going, and I think it was more or less accidental that I wound up being the first one on this panel, but nonetheless I'm going to take advantage of that and give you an overview of the health and human rights field, and it is, we're going to try to apply it to the United States, but it is a global movement. And some of the things I say, most of the things I say, many of you are going to be familiar with, but I hope not necessarily in the context. The basic argument I'm going to make is that all human rights are interrelated. And it's a big mistake to look at just one or two all by themselves and try just to work on that. And I mean, if you can make an argument that the United States has always considered itself a leader in civil and political rights, and obviously not in economic, social, and cultural rights. But that, I'm no surprise to most people here, we've lost our leadership role there too. And this has had even more devastating impact on economic, social, and cultural rights. This I'm indebted to Harold Koh, current human rights expert at the State Department, who gave this talk 7 years ago, in 2007, I attended. And he says that there are 4 basic eras in human rights. And I actually found this persuasive, so I'm going to share that with you. The era of universalism, when the movement started. The era of institutionalization, from 1956 to 76. The era of operationalization, when we actually started getting organizations together that promoted human rights. Then he called the era of globalization, from 1989 to the present, which he had broken out into 3 areas. The era of optimism, from 1989, fall of the Berlin Wall, to 2001, 9/11. The era of pessimism, basically the Bush years, and the era of hope and change, which I put a question mark there, and we'll see. And then D, what's going to happen after next week, is a really important question. All right? So we'll go back and look at, this is where it began under Franklin Roosevelt with the Atlantic Charter, him and Churchill on the bottom there, then Roosevelt's Four Freedoms speech, then after his death under the leadership of Eleanor Roosevelt, the drafting of the Universal Declaration of Human Rights, and the founding of the United Nations. That era ended with we talked about the fall of the Berlin Wall. This was a very, very optimistic time. Many of you can remember that. I mean, this was incredibly optimistic time because up till now, the world had been divided in this civil and political rights with the U.S. bloc and the Western bloc, and economic, social, and cultural rights, the Soviet bloc, and there was like nothing came in between. And this looked like a new era of human rights was coming. And in 1994, shortly after that, the fall of the apartheid government in South Africa, and we were rolling, man, right? Everything looked like it was, things were on track to have a new era, if you will, of human rights. Then we had 9/11 and Guantanamo, use of torture, force feeding, and other things, and the United States saying that, no, actually we didn't mean everything in all these declarations that we've signed, and Geneva Conventions. They actually don't matter. If we're under attack, if we feel fearful, then we have to change the rules. Because after all, the United States is the leader in human rights. And so whatever we say goes. And we went through a pretty horrible time. When President Obama was elected, he said 2 things he was going to do. Promise the United Nations, promised Americans, within a year I'm going to close Guantanamo, and I'm going to stop torture as official policy. As far as we know, he actually did stop torture as an official policy. But Guantanamo is, there are fewer people there now, but obviously it's nowhere near being closed, and there are no plans to close it. So it's a big problem. Now, where did civil and political rights begin? Was at Nuremberg. Many are familiar with this. There were one big trial and then 12 subsequent trials. But the big trial at the International Military Tribunal with the 4 major Allied powers. Everybody says that, but it's actually the 3 major Allied powers and France, which was occupied during the war. Anyway, they held a trial of major war criminals, and out of Nuremberg came the Nuremberg Principles, which you all know, even if you don't know them as the Nuremberg Principles, that there are such things as war crimes and crimes against humanity, that individuals can be held personally accountable for committing them, and that the defense, I was just obeying orders, is not a defense. All right? Those apply to the United States as well, even though we haven't applied them to our torturers yet. But someday someone will. And then there was, after the big trial, there were subsequent trials held just by the United States, 12 of them. This is from the first trial, the doctors' trials. We already talked a little bit about doctors. And out of that came the Nuremberg Code and requirements for informed consent, very, very significant good document. Following the war and the trials, we have many, many major human rights documents, but I think these are the most relevant and most important for us today. The first, of course, is Universal Declaration of Human Rights. It's a declaration, not a treaty, but nonetheless, most people, most scholars believe the most important human rights document in history, and I certainly think that's true. It did not distinguish between civil and political rights and economic, social, and cultural rights. Put them all in the same document, and that was certainly the goal of the human rights advocates who helped draft that. And we have the Geneva Conventions, again in 1948, the same year as the Universal Declaration. The only conventions that have been signed by every country in the world, even us, even though we don't follow. The International Covenant on Civil and Political Rights, which was the one championed by the United States, which was up for ratification in 1966, same year as the International Covenant on Economic, Social, and Cultural Rights. So the two types of rights were separated into two different documents. For historical reasons, again, the Cold War, but nonetheless, it's had major damage in the whole human rights field because it implied that you could separate human rights, that you could have economic rights without political rights, without civil rights, or you could have civil rights and starve to death, and that was fine, right? Then the two big conventions that are related mostly to health, besides these, are the Convention on the Right to the Child and the Convention, and CEDAW, the Convention on Elimination of Discrimination Against Women. And it is important, I think, to know, and most of you know, that in human rights land, states have, and it's all about the obligation of states, states have special obligations to women and children. And some people think that's not right, that that's treating people paternalistic, but it makes perfect sense. These are I'm not saying women are vulnerable, children are the most vulnerable people in the world, and obviously government should have special obligations to make sure they thrive and do well. Some of you are following the hurricane in New York, know that the major teaching hospital at NYU had to evacuate itself just 2 days ago. The first people, that was a disgrace, by the way, they had to evacuate for the second, but the first people they removed from the hospital were the newborns, and nobody thought that was the wrong thing to do. All right. My current career is trying to reconcile and combine the fields of bioethics, health law, and human rights, and this is just a quick schematic that tells you kind of the difference. Bioethics is about doctor-patient relationship. Health law is about law, which is nation-bound, laws of individual nations and states, and it's based on politics. We're watching right now. And human rights is global, species level, and it's promulgated by treaty. But the treaties require that the individual countries that sign them adopt the principles in their own domestic law. Right? And then the people that have a lot of big role in actually implementing treaties related to health, laws related to health, are physicians and nurses and other healthcare professionals. So they all actually do work together. And international human rights law also privileges physicians on a lot of the documents. The Geneva Conventions, for example, even when you're a prisoner of war, if you're a physician, you cannot be prevented from practicing your profession consistent with medical ethics. International medical ethics declarations also tell doctors what they can do in situations of war, force feeding, different things like that. Okay? Medicine and public health are usually differentiated, and we're mostly talking about public health today. Medicine uses the language of bioethics, doctor-patient relationship, treatment, and autonomy of patients, whereas public health, at least as Jonathan Mann, uses the language of human rights, populations, prevention, and often social justice. And so I'm going to argue there's sometimes seen as a tension between human rights and social justice, but I think that's just not right. You have to love the economists, even they recognize that everything is not about the wealthiest in the world. But they keep asking the question, do we really have to help the poor? Does inequality really matter? Is inequality all that bad? But again, even the economists, it's totally dedicated to market economics, says, yes, inequality can get too bad, and right now it's at the worst that it's ever been, the difference between the rich and the poor, and that actually governments do have an obligation to help the poor of the world. Right? Jonathan Mann, the late Jonathan Mann, a friend and colleague, was probably the most influential person in the world in starting the field of health and human rights and in preaching what we're talking about today, that the determinants of health are social. And Jonathan went beyond it. He said the determinants of health are social, therefore, basically public health is revolutionary. In order to change the determinants of the society, you have to change the society. And that's our goal. Jonathan was very clear. That's our goal as public health professionals, to change society so that the determinants of health are available to everyone. We've heard what they are already. They're not just healthcare. Healthcare is like real important, but it's just part of this giant package of food, clean water, sanitation, housing, education, the determinants of health. And if you have any trouble seeing them, just take a look at what's happening in New Jersey and New York and what are putting people at risk, what people need just to continue to live and survive. Those are what they need to be healthy as well. The health and human rights movement is based on the notion that all human rights are interdependent, as Jonathan would say. Health and human rights are inextricably linked. Right? You really can't be healthy without having human rights. Human rights are universal. They're based on human dignity. They're actually enforceable. They include the right to health, but this is part of it. All based on the non-discrimination principle that all human beings are equal and cannot be discriminated against, and, as I said before, special obligations to women and children. Now, I don't want to say it's a big debate, but a little bit of a debate. You hear it. Some people now are saying, well, human rights has kind of run its course. It didn't work. We got to do something else. We got to do social justice, which is sometimes seen as different than human rights. I think human rights is dedicated to social justice, among other things. But nonetheless, you hear that. Other people say we've got to concentrate on bioethics. More people say we have to concentrate just on economics and efficiency in the market. And then, obviously, lots of people say, too, where really the basic support is politics. Well, I'm going to look at a couple examples, and then we'll wrap it up. Just to show how complicated it is. In South Africa, after apartheid, South Africa did what 80 other countries have done. They basically took the two treaties, the International Covenant of Civil and Political Rights and the International Covenant of Economic, Social, and Cultural Rights, and put them in their constitution, brand new constitution. All right? So they made all of the human rights, all basic human rights, constitutional rights in their country. All right? Franklin Roosevelt wanted to do that in the United States, by the way. He wanted to have a constitutional right to health, Social Security, to jobs, to education, all the basic things. Okay? He obviously died before he was able to put that into motion. Well, 80 countries of the world, mostly the countries that have been created since the Universal Declaration of Human Rights, have put them in their constitution. So the people that say, well, human rights aren't really law, well, in those 80 countries, they're the highest law there is. Now, human rights also gives countries that don't have the resources to implement human rights immediately the obligation to progressively realize them, right? To at least have to have a plan to realize them and to move toward realizing them. South Africa is a classic example for a couple of reasons. One, they actually took it seriously and tried to make progress toward realizing the right to health, but there were some major problems. The president of the country for years didn't really believe in HIV/AIDS, so NGOs like the Treatment Action Committee had to take the country to court to try to enforce the right to health. When a drug company said that they would give nevirapine free to the women of South Africa, well, of course, there's no free lunch. You did have to have infrastructure to deliver the drug, and the government refused to take the drug. The Treatment Action Committee brought the case to court. The Constitutional Court in South Africa ordered the government to come up with a national plan to make this distribution work. Right? Did they do it? No, of course they didn't do it. Bottom line today, they have a great document, but have had lots of problems in implementation in South Africa, and there's really some danger that country is now losing losing ground. But it also illustrates another point, that in the world, power is no longer a monopoly of the states. Right? You all know that. No longer a monopoly of governments, even though major armies are still a monopoly of governments. But power and wealth is concentrated now in transnational corporations. Right? If we get rid of the top 10 countries, the next 100 are corporations in terms of annual revenues. So Kofi Annan recognized this, and he made a big movement to try to start a global compact where individual companies would agree to be bound by human rights laws. They're not. Human rights laws are written for states, right? For governments, not for corporations. But we have to figure out a way to get the corporations on board, or we're never going to get useful, long-lasting change in the world. Corporations are bound by these four things. Everybody is: crimes against humanity, war crimes, child labor, and non-discrimination. And we have found some success in enforcing them through the courts, even in the United States. Most famous case being the Pfizer experiments in Nigeria, where the Second Circuit Court of Appeals said the Nuremberg Code is now part of international human rights law and can be enforced under the law of nations theory in the United States courts under the Alien Tort Claims Act. Incredible case. Didn't go to the U.S. Supreme Court. Not sure how this U.S. Supreme Court would rule. Just as happy it didn't go there, actually. Well, we talked about Guantanamo already. But the point again, that's to remind you, is that we're no longer the leader of the world in civil and political rights. And if we don't take our own civil and political rights seriously, we're certainly not going to take economic, social, and cultural rights seriously. So we've got to get that straightened out. And this is kind of the world symbol of the United States now, are the drones. And it is a continuous scandal that the president will not release the documents which justify, or he believes justify, under international human rights law, they're written by Harold Koch, the use of drones. We'll talk about that later. But it's had major implications. The Taliban, do we care what the Taliban says? No, they're not human rights people. But they have said they're not going to permit polio vaccine in Pakistan until we stop using the drones. Well, that's an empty threat. They're not permitting polio vaccination anyway, since the killing of Osama bin Laden and our use of public health workers to try to get his identity straight. That was a big mistake. The Taliban has never been a favorite of human rights people. My friends at Physicians for Human Rights, before the Afghanistan war, did this study of the Taliban and their war on women. Again, point, not to overemphasize it, in human rights land, governments have special obligations to women. Women equality is not negotiable. All right, and even in pre-war Afghanistan, insistence had to be that women get treated decently. They don't, obviously, in either Afghanistan or in Pakistan. But every once in a while, there's a possibility that an individual case or a scandal can change a society. God knows whether Malala is the case, but it may be. I mean, she was, as you all know, a young woman, 15-year-old, who was an advocate for women's education, which almost everyone agrees is the key to educating young girls, is the key to the future of the world, but also of health. They tried to kill her, tried to assassinate her. She was severely wounded. They tried to kill her again, but she was successfully transported to England, where she's being treated right now. Her case could be a cause célèbre. It's a cause célèbre in Pakistan now, and it could help move that country to women's equality. I really actually think it could. And that's the way human rights works. It really is based on horrible events. I mean, nothing as horrible as the Holocaust or World War II, but that's the idea. Out of horrible cases come human rights, and it could happen in Pakistan as well. It could even happen in the United States. I'm not as, I don't want to say I'm pessimistic about the United States, but the United States has now set many records. We heard some records about poor children and nutrition in young children. We now have more prisoners in our jails than any country in the world, by numbers, and more people per capita, obviously, since we're a smaller country than any other country in the world. We're number one. It's the first time we've ever been number one in this. We used to be proud of saying, how we castigate the Soviet Union when there was a Soviet Union for the gulags and the horrible prisons they had, and China, how awful they are on human rights. Well, we're now number one, so we can't castigate them anymore. And that's a major scandal. As bad as that is, and I'm just going to quit down so when I move forward. As bad as that is the U.S. Supreme Court, which the week the Affordable Care Act was heard by the U.S. Supreme Court, the U.S. Supreme Court ruled that routine strip searches for everyone arrested in the United States, even for a traffic violation, are acceptable under the Fourth Amendment. No problem. That's a reasonable search. Routine strip searches are reasonable? Is that possible in the United States of America? I mean, we've just taken what's left of the Fourth Amendment, right, and thrown it out. But basically, we've been doing this routinely. We've taken whatever's left since 9/11 of civil and political rights and gotten rid of them. So it's an open question whether the United States, we know we don't take economic, social, and cultural rights seriously, but I don't believe we take civil and political rights seriously either. This is a big problem, and the bigger problem is, I want to say nobody, but nobody seems to care. There's no outrage over this case, the Florence case, that I've seen. Everybody thinks it's fine. On the other hand, every once in a while you get a success, and this is Harold Koh, obviously our Assistant Secretary for Human Rights, bringing back the blind Chinese dissident after Hillary's trip to China. So sometimes we get a success. It's symbolic and it's real. So I'll just close with the notion that I think human rights is really, really important, but it doesn't happen by itself. It requires broad political support in a democracy, and it requires governments to be criticized, including our own government, when they fail to follow basic human rights doctrine. Thank you very much.
Thanks very much, George. Next we have Patricia Illingworth from Northeastern University. It is. You know how to do that?
I'm going to talk about some themes that came out of a book that I recently wrote called Us Before Me. And basically what I'm going to suggest is that if we treat the concept of social capital as a moral concept instead of just as a social science concept, that we can increase it, that it can flourish, and because social capital is important for health, that it's an important social determinant of health, we can also improve health. And then I'm going to say a little bit about understanding health as a solidarity right. So one of the problems with social capital is that it can be defined in many ways. There are different kinds of capital, physical capital, which is something like this computer, physical objects that increase value, human capital, skills and talents that improve value, and financial capital, investments that create value. Social capital really underscores the idea that social relationships have value. And I choose a definition that came out of something called the Sarkozy Report a few years ago that was authored by Amartya Sen, Stieglitz, and Jean-Paul Frétouzy. And basically they define social capital as social networks and associated norms of reciprocity and trust. And the emphasis they have on reciprocity is really what's called generalized reciprocity, which is a willingness to help and give to others without expecting immediate or direct reciprocation. Social capital benefits the people who have it, it benefits the communities that they live in, and it benefits communities connected with them. One good example of social capital is Neighborhood Watch. There you see people participate in watching the neighborhood, making sure that it's safe. They can report harms to the community. And what you see is that the people who actually participate in Neighborhood Watch are not the only ones to benefit, but the community at large benefits. And so social capital, some social capital at least, is also a public good, and it has these kinds of public good qualities. It's non-excludable, which means that we can't exclude people from benefiting from from social capital, and it's non-rivalrous in the sense that my use of social capital does not exhaust it. Well, what that means really is that social capital isn't effectively distributed through the market. Social capital is a social determinant of health, and it also is implicated in a number of the other social determinants of health. As you know, there's a long list of social determinants of health, but social exclusion is one social determinant of health. Inequality is another, and in a sense, we know that where social capital is low, also where there's a great deal of inequality. Where social capital is abundant, people tend to give more to communities, and philanthropy is up, so poverty is down. Places of employment are good sources of social capital when they're run effectively, and social capital can alleviate stress. So there are many ways in which social capital overlaps with the social determinants of health, in addition to being one itself. Despite the benefits of social capital, the normative system that we have really, our predominant norms are not norms that contribute to it. So we are really, we sort of have norms of self-interest, individualism, me first. And those clearly aren't going to be conducive to social capital. But social capital is not purely a good thing. It has what's called a dark side, and that is to say that people tend to make choices about who they spend time with and who they have social relationships with on the basis of what's called homophilous preferences. That is, they like people who they see as just like them. And so that's been observed with respect to race, gender, socioeconomic, religion, and just many, many facets. So that means that a lot of social capital can exclude people. What in the social capital literature is called bonding social capital, and it leads to a kind of tribalism and kinship. And given the value of social capital, that can mean that some people experience what's called network poverty. In part because of the norm of self-interest and the collective, the public good qualities of social capital, people may be reluctant to contribute to it because others can benefit from it. So social capital has this free rider problem, which means that it will decline to some extent, at least not flourish. So things that are not delivered well through the market, and such as public goods, often can be managed more effectively through norms and law. So it seems to me that social capital actually has a number of ethical qualities, and that it's fair to say that it is an ethical concept, and that if we treat it as one, and so in a sense we give it a moral upgrade, that in fact social capital would flourish, and so too for the health benefits that go with it. So Peter Singer, in a book called Practical Ethics many years ago, identified 3 characteristics of the ethical. And I think that social capital fits each of those very well. The first is that ethical concepts concern conduct between and among people. So social capital obviously does that. What it does is it shifts the focus from individuals to networks of people. Ethical concepts also are universalized. And in this case, what that means is that we would choose networks impartially. And that, in a sense, the option of homophilous, forming networks on the basis of homophilous preferences would not be ethical. And then ethical concepts are prescriptive, which is to say that we can ask people to act on the basis of it. We want those kinds of concepts to be promoted. That's Kant and Mill, usually enemies, but on the basis of the matter of universality, they really agreed that anything that is ethical has to be impartial. And I think that this has a very important implication for social capital, which is that it basically would override the dark side of social capital. If you treat social capital as a moral concept, then the option of choosing your social networks and social ties on the basis of homophilous preferences really disappears. And most ethicists, I think, would agree with that. The other thing about treating something as a moral concept is that morality trumps the non-moral. So in the case of social capital, what that means is that even though people might want to act on the basis of self-interest or, and not contribute to social capital, that would be a non-moral preference. And if social capital were treated as a moral concept, then they would be obligated to do it, just as they're obligated, for example, to tell the truth, even though they might like to lie. The other important thing about treating social capital as a moral concept is that we basically put it into the choice architecture. And by doing that, again, enhance the likelihood that people will make choices on the basis of it instead of on the basis of self-interest. So this little book, Nudge, by Thaler and Sunstein, sets out a model basically suggesting that where you place things, for example, if you put healthy food at the front of the cafeteria and you put unhealthy food at the back, people will make choose the healthy food. Well, it's the same with moral norms and laws. If we make some norms prominent, people will choose those. And so by really converting social capital into a moral norm, we put it in the choice architecture. Now, if you take social capital as an ethical concept, it seems to me, and you have this obligation to universalize it, it seems to me that we then would have global social capital as well. And a lot of people are skeptical about the possibility of global social capital because of the problem diversity has for social capital. But again, if you treat it as a moral concept, you really don't have that problem. And I think, in addition, when we actually look at the world and we think about it in terms of the definition of social capital that I gave, it's pretty clear that there is a lot of global social capital. So, for example, we need norms and networks. The networks are clear. We have global governance networks, civil society networks, transnational business networks, immigration flows, and financial and cultural flows. And we also have networks of trust and reciprocity. And indeed, we have networks of the favored kind of reciprocity, norms of favored kind of reciprocity, this generalized reciprocity. So, for example, international service, where people go to help people in other countries, really is a generalized reciprocity. There's no expectation of direct reciprocation. Social enterprise, also businesses oriented towards helping people in developing countries and not towards profit. Global philanthropy, the same kind of thing. Organizations like Doctors Without Borders, and then the Twitter revolution, where Americans and all over the world actually sent alternate IP addresses to Iran, basically a kind of activism. Again, it's a generalized reciprocity. So I think that I think social capital is a moral concept, and I think moral concepts like the law are dynamic. They can change. We now have a sort of green ethic, and I think we could have an ethics of social capital. To some extent, that depends on how we treat it. But I think the other thing is, when we think about the social determinants of health, when we think about how important the social determinants of health are for health, we may want to reframe or at least supplement our understanding of the right to health and to include kind of solidarity right, to look at it also as a solidarity right. Now, these solidarity rights, which I actually learned about in the course of hopes, so blame her if you don't agree with it, these solidarity rights are hard to get some information about. But there is a document that I located from UNESCO in which sort of sets up the 3 generations of rights: first generation civil and political, second generation cultural, social, economic, third generation are these solidarity rights. And the idea of these solidarity rights is that they are based on the community, that they come to some extent from the inside, and that they can't be protected only through state action, for example. So this quotation here: third generation rights are predicated essentially on the notion of solidarity among people. Such rights, in that they reflect a particularly human conception of community life, can as a result be achieved only through the joint efforts of all those representing social interests involved. So some of the rights that have been identified as solidarity rights are the right to self-determination, a right that belongs to peoples and collectives, the right to development, again, is something that not individuals can hold, but the collectives need to hold. The right to peace is the right of not even nations, but of peoples. The right to healthy environment, similarly a right that belongs to all peoples in the world, and really is a good example of why, in order to have a healthy environment, the community needs to cooperate. We all need to change our behavior. It's not something that can come from the outside. So the question is, does it also make sense, in light of the important role of the social determinants of health, to think about health as a solidarity right? And I can't say a lot about that. It's obviously a big topic, good place for research. But the Institute of Medicine says, you can find these things in a lot of different places, but they say the public's health can be achieved only through collective action, not through individual endeavor. Acting alone, persons of means may procure personal medical services and many of the necessities of living, yet no single individual or group can assure the conditions needed for health. Meaningful protection of the population's health requires communal effort. Again, suggesting that this is really a solidarity right more than it is, or at least in addition to being a social, cultural, economic right. What would it mean? I think understanding the right to health as a solidarity right has some explanatory power that doesn't exist with understanding it as a social, cultural, economic right. So, for example, the right to health would impose obligations on many entities if it were a right, if it were a solidarity right. That would just follow automatically. It would impose obligations on nations, pharmaceutical companies, transnational organizations, civil society community, individuals, philanthropists, and probably more. Now, already with some of the work that Paul Hunt was doing on pharmaceutical companies, we could see these steps being taken with the right to health and making other kinds of entities responsible for it other than the state. But that may be more of a stretch with second-generation rights than it would be with solidarity rights. So solidarity rights seem to have more explanatory power with respect to who we want to hold responsible for health. And the last slide. I think that if if we understood the right to health as a solidarity right, there would be all kinds of policy implications that would follow. I mean, Wendy and I have been working on healthcare and immigration. I think more inclusive healthcare policy, with respect to immigrants as well as education, would be an implication of understanding it as a solidarity right. Improved mental health would be important because if you're going to forge all these social networks, you can't really be depressed all the time. Minimizing medical brain drain. If we had some solidarity, we would really express that solidarity with other nations by not depriving them of their health professionals. And I think there would be ways of incentivizing philanthropy through, if we were to understand health as a solidarity right. And I just like that little guy down there, so I put a picture of him in there. Exactly. He would flourish. Okay, thank you.
Thank you. This be a class. I'll give it. Thank you very much, Professor Illingworth. So next we will have Sofia Charvel of the ITAM Mexico. I want to say just briefly as Sofia makes her way up here that the next two speakers have many things in common. But one of the things they have in common is they're joining us today after having spent last night in New York City, which may be one of the strongest things they have in common. Sofia made what seemed like a fairly simple choice to fly to Boston through New York. And she discovered when she arrived there yesterday that it was anything but a simple choice. It was, in fact, an invitation to spend the evening last night in the airport, perhaps seeing something of our future before us in some way. So thank you very much for making the effort to get here after a difficult day yesterday, difficult evening last night. Sofia Charvel.
Good afternoon. First of all, I want to thank Professor Wendy Parmet for inviting me to this important day to participate in this important meeting. It is an honor for me also to share the panel with such personalities. I also want to apologize because of my English, and I will try not to read, but it is sometimes easier when it's not your first language. In Mexico, I direct a health and law program, and it is mainly focusing in the legal analysis that takes a human rights perspective to improve health policies. But in Mexico, it's not very common to have things that are done with health that you work them like in an interface of other disciplines, like health issues are for doctors. And we really just have like two programs in Mexico that try to link law and public health. So I really have the honor to have one of those programs. Today, I will speak about cases of Mexico and our legal frame that treats human rights. It's very different from what you have, but I am convinced that forums like this help us find better ways to attend the health issues at home. If we read the Mexican Constitution, particularly the first chapter, which is called Human Rights and Their Guarantee, what we find is that Mexico is a country that gives full human rights protection to every person in its territory. And furthermore, these rights are not only recognized, but they are fully protected and guaranteed judicially and by every other authority level, federal, local, and municipal. Let me explain you a little bit about this. In June 9 of 2011, our Congress approved by a really big majority the revision of the Constitution that expressly recognized the human rights in the Constitution. And then, since this reform, the human rights and international treaties containing rights have constitutional rights. But this goes more. In the first article, it says, like, we have all that. We recognize all the human rights we have in the Constitution and in the international treaties that Mexico is part. So this means not only in the international treaties of human rights, in every international treaty that Mexico is part, and that we can think it has a human right, then our constitutional will recognize it. So recognize and explicitly states such recognition and protection of the human rights. But which human rights are protected? According to Article 1, not only those explicitly recognized, but, as I said, all the ones that are in the international treaties. And we have a lot of rights established in our Constitution. It's like a very big list, but not discrimination, health, education, right to nutritious food, housing, potable water, freedom of speech, between others. Human rights are protected because that says our Constitution. In our constitutional system, rights are not only recognized because the Constitutional says we will recognize, but are fully protected and guaranteed judicially and by every other authority level, federal, local, and municipal. Then, if we see this in our Constitution, we can think that inequality among individuals should be minimal and health outcomes should be positive. But let me show you some numbers that I have. But before, it's very important to say that also about the protection that we have in our Constitutional, we have to follow the principles that were included in our Constitution of universality, indivisibility, and progressivity to prevent, and then the authority also has the obligation to prevent, investigate, and punish and repair any human right violation in accordance with the law. So if you listen to all this constitutional reform, I think that the right place to live is Mexico. No, because all the rights you have and the protection and the guarantee and the recognition. But then the distribution between the constitutional norm and our human development level in health, it doesn't make any accordance with the constitutional rights we have. So here, Coneval is the one that makes the measurements in poorness in poverty in Mexico. And this is more or less the numbers. 19.4% of Mexican population does not have enough income to cover basic food necessities, which means that 19.4% suffers malnutrition or hunger. Maternal mortality was at 50.7 per 100,000 births in 2011. Infant mortality, 16.7 deaths, 1,000 births percent. So we can conclude that our constitutional norm protect or say without good and sound public policies and mechanisms for its guarantee, constitutional human rights protection is only a goodwill letter. Mexico still needs to work toward better implementation of the human rights. Nonetheless, all is not bad news. I want to talk about two main cases that in Mexico have been very helpful trying to reach like a better standard of our health protection system. Several reforms, public health policies, and changes have been made which have had positive outcomes in health. I will speak of two initiatives. One is called and recognized as Seguro Popular. It's a Mexican health reform implemented in 2003 with Seguro Popular that intends to establish universal health coverage. The overall goal was to provide access to an explicit and comprehensive package of essential health services and specialized interventions associated with specific diseases and health conditions to 50 million Mexicans who had previously been excluded from public social insurance. And the other is a national agreement the National Alimentary Health Agreement. This is a public policy to address obesity with three main goals: revert the obesity, stop the growth and prevalence of obesity, and let's accelerate in adult population the obesity. Seguro Popular was a solution given to grant poor families with no social coverage, with good quality level health protection services. In 2012, 9 years after it was created, it achieved universal coverage, and even though in reality the evidence does not prove this kind of governmental position, specialized researchers said that we are still missing 20% of our population to achieve full coverage. As April this year, more or less 52.6 million Mexicans previously uninsured were incorporated to Seguro Popular. The World Health Organization defines universal health coverage as the access of all people to comprehensive health services at affordable cost and without financial hardship through protection against catastrophic health expenditure. With Seguro Popular, Mexico has really advanced in universal coverage, and it has three components. All people have access to health service funded by publicly organized insurance, and that's true. Regular access to a defined package of health services, and system that guarantees to all on an equal basis the maximum attainable health results. But it has proved, and it has very good outcomes. For example, that improvement in maternal mortality and mortality in children younger than 5 years have been larger for the previously uninsured than for Social Security beneficiaries. Mortality in children younger than 5 years fell by 11% for the population without Social Security, compared with 5% for those with access. And then there are the numbers also for maternal mortality. However, women without Social Security covered by Seguro Popular experience a 66% higher mortality than the other systems we still have. However, the challenge in the near future to Seguro Popular, now we have more or less the universal coverage, but the challenge will be to have an improvement in the quality and efficiency of the health services. An ideal to diminish gaps between the quality in health services provide between rich and poor states, and between Mexicans and the different income of educational level. And the difference is very easy to notice. To obtain a better quality, we need to improve in many aspects, like specialized medical doctors to apply the correct treatment, better hospitality infrastructure. The waiting time should be much shorter instead of waiting 4 hours or days to have the needed medical attention. And an example of what I'm saying is represented by the numbers we can find in the pregnant women who are in need of an emergency obstetric care. Often happens that they are rejected from the hospital because there are no more beds for them to be attended, or there are no more doctors because they are busy with other patients, or sometimes they have an hemorrhage and there is not blood bank nearby to help them with the needed. And then it's why we have our number of maternal mortality. In conclusion of Seguro Popular, we can say that the data suggests that Mexico still needs to expand coverage. Despite having achieved universal coverage, Mexican citizens do not have equal access neither to health care or to financial protection against the potential cost of severe illness or injury. And citizens' perception against official data population survive. 20 report no health coverage, 40% report access to limited health package and protections for some condition considered catastrophic, and 40 report access to unlimited coverage. Now I will speak of the other public policy that I think in health that I think that has much better outcomes in health. The National Alimentary Health Agreement. It's a public policy that, as you know, obesity in Mexico since 1980 and overweight prevalence in Mexico has tripled. 39.5% of adult males and females are overweighted, and 31.7% can be classified as obese. Approximately 70% of our population has an unhealthy corporal mass index. Children and teenagers are not exempt from this disease. So the goals that I gave in the first moment when I say that I was going to explain 2 actions, those goals of this national alimentary health have 10 objectives that are intended, that are here, the ones that says promote physical activity, increase availability and consumption of drinkable water. These 10 objectives are intended to generate health, lifestyle, and environment for individuals. Thus, it affects some of the social and environmental determinants of obesity and should be considered a very important public policy for the prevention of obesity and overweight. However, 4 years after the signature and agreement, what has been the outcome? Can we say it has produced effective public policy and programs? And we can say yes in the case of Mexico. It is intended to generate healthy lifestyle and environment for individuals. Thus, it affects some of the social and environmental determinants of obesity and should be considered a very important public policy for the prevention of obesity and overweight. But it is important to say that in Mexico, for this program, we have found a problem that is linked with illegal instrumentation. Our problem is not the design of the public policy. Our problem is the implementation of the legal status. For example, sometimes we cannot have the verification or we don't have the empowerment to establish the public policy the way we want. So one kind of conclusion would be that we should try to empower more our authorities to establish the public policy. We cannot, as lawyers, we are also analyzing that the human rights and health outcomes cannot leave aside the resolution that the Mexican Supreme Court generates. We are moving every time more to a Supreme Court that makes resolutions in human rights subjects, because before we have a Supreme Court that mainly makes more things about taxation. So we are moving to a new and a little bit more active court, but we are far away to have the interpretations we need to improve Mexicans' rights to health, mainly for those who cannot access to justice. It is risky that now that these kind of problems are arriving to court, people start to receive money instead of health attention as compensation of the deficiencies in the social health system. That action can help to have a population not so unhappy but sick. And this kind of resolution will take us far away from a culture of prevention and promotion of health in our society, and that can make the way to be longer and harder to achieve the right to health protection we have in the Constitution. For conclusion, I think mainly in the case of Mexico that for human rights to be effectively observed and protected and to have an impact on health outcomes, constitutional recognition is not enough in our country. Firm and effective public policies are needed. And furthermore, all these public policies must be put in place by legal instruments that have the possibility of being enforced effectively, because that's always our mistake. We have beautiful designs, but we cannot make them effectively. By a competent authority to generate a high standard in the development of our human rights to health, and then we will start having better health outcomes results. Thank you.
Well, thank you all, and thank you, Sophia. We're now going to have our fourth panelist, who is Anya Rudiger from Nesri in New York. And as I said before, she spent last evening in New York because that's where she lives. And as of 6 or 7 a.m. this morning, there was certainly no certainty that Anya would be able to get out of New York. She found her way, I believe, to Chinatown, and one way or another managed to get here. So we're very happy that you're able to do that, and thank you very much for making the effort to join us today.
Thank you so much for giving me refuge here from the disaster zone that is New York. I really appreciate it.
It's okay. Good.
So yeah, I was taking these notes while the storm was about to strike. So it's kind of surprising that I didn't make it about climate change, but I did not. But it probably does lack a bit of the moderation that may have been appropriate for a panel like this. But if you bear with me. So I do want to talk about how the human rights approach can help us look at the social determinants of health a bit differently. That was what I saw from the inspiring sort of concept note of this institute. And I'd like to focus on looking at the role of the market in producing health outcomes and the potential alternative of public goods. as you heard from Martha in the beginning, there is a huge overlap between economic and social rights and the social determinants of health. And I would kind of like to use the human rights approach to see, to drill a little deeper and see what determines the social determinants of health. So, or in other words, what are the root causes? What are the root causes of inequities and social injustice? And then what connects the different determinants and the different rights? Again, rights are indivisible, and so I would argue are the various factors that we call social determinants of health. And then what connects the struggles against the specific injustices? We have struggles for the right to health, the right to health care. We have struggles against poverty. We have struggles for housing rights. So, you know, the human rights framework can provide a common linkage between those struggles. And finally, what is our vision for a society that achieves health for all? And I feel like we can go to the human rights frame and be quite creative with that while still being true to the essence of what we define as human rights. And I'm not promising to answer all of those questions, but I just wanted to take those as a springboard and go through some of the issues quite quickly to just see how can we look at things a little differently. So I'd like to look at what happens to health and what happens to human rights in the market. So I want to briefly look at all of the economic and social rights, healthcare, education, housing, work, social protection, food and water, and just want to give a quick sort of snapshot what I think is what happens to these rights in the markets and what the health impacts are of that before then drawing some conclusions from that. The photographs, by the way, come from a group that I work with in Vermont, the Vermont Worker Center, that's been leading a successful human rights to healthcare campaign in Vermont and is now broadening this to an overall campaign called Put People First, which is, for example, asking for a human rights-based budget and revenue policies. So just if we look briefly at the human right to health care, which is the field most familiar to me, and all my remarks are concerned the United States. So healthcare here is obviously sold as a commodity. It's sold to those who can afford it, and access to healthcare depends on payment. Obviously, there are exceptions. There are residual public programs, but these are severely underfunded. And so the business model of insurance companies does depend on limiting or denying care. That's the way insurance works in general. In any field, you insure against something not happening. And if it does happen, the insurance company actually loses money. They didn't lose any money here over the past few years. Indeed, in 2009, the insurance companies made $12 billion profits. And I think it was the year before that 700,000 families went bankrupt despite most of them having insurance. So we have a system, a healthcare system in the United States that subsidizes market-based insurance companies to the detriment of people's health. There's widespread evidence internationally, most, I think, succinctly put by an UNRIS study about commercial healthcare systems having much poorer health outcomes than public health systems. In the U.S., again, you all know the facts. 45,000 people die each year just because they don't have any health insurance, not even taking into account any of the other factors. We have tremendous disparities between white people and people of color, African Americans and Hispanics, as represented here in the survival rate for cancer, which is much better for whites than for African Americans. If we jump to the human right to education, what we're facing here in education in this country is public schools are being closed or they're privatized. Public funds are, in fact, channeled toward privately run schools, which then further undermines the already fragile funding base of public schools, which are mainly funded through local property taxes, a very problematic funding model. Children are actually pushed out of school. That's usually part of part of the pressure on schools to stay very competitive, so children that are seen as not fitting into the mold are being pushed out. Fits also nicely into the sort of lack of attention to civil and political rights that George was mentioning earlier, in terms of being very schools having become a very strict security environment. We can say that we have a two-tier system that quite effectively discriminates against students of color, with students of color always be found in the poorest schools, the least funded schools, the not well-performing schools, and many of them being pushed out of schools and actually landing in what we call the school-to-prison pipeline. Health outcomes, as you all know, are highly correlated with the education level. There's multiple theories as to why that is so. Suffice it to say that in the situation that I just described, children are denied their full development by either being pushed out of schools or relegated to underfunded schools, and a disproportionate number of children of color is denied access to quality education, even though education actually, among all the rights that I'm talking about here, is the only right in this country that is recognized as a public good, yet this is eroding very, very quickly. We jump to the human right to housing. Housing clearly in this country is commodified into real estate. It is traded in a stratified marketplace. Again, only people with a significant amount of money can actually afford comfortable housing, and then you have lots of different tiers depending on how much money you have. As the Special Rapporteur on the right to housing said, it's actually the financialization of housing that caused not just the housing crisis but also the economic crisis, and that this is a model that is entirely unacceptable for treating one of the basic fundamental human needs. In this country, we have huge public subsidies, actually, for housing, but they're mainly given for acquiring private property, for paying mortgages. So there's huge public monies flowing into that. So right now, I think the figure is about that public policies for housing spending around 3 times more for private housing for mortgages than they spend for all affordable housing programs together, including dealing with homelessness and so on. We also have a big privatization push. More and more public housing is converted into private housing. Public housing management is being outsourced, and public land is being sold off to developers, and tax breaks are channeled to private developers. The health outcomes are also fairly clear. Housing is, again, very highly correlated with health. I think it's important to say that the housing crisis in this country right now is not a crisis of housing shortages, but a systemic neglect of people's needs. We actually have way more enough housing here. We have empty homes than people who need to be housed, and yet the market cannot match the two. So we have increasing homelessness and all the health impacts that come with poor and unsafe housing conditions, with foreclosures, with high housing costs, and housing, clearly where you live, really impacts all your other human rights very significantly. We look at the right to work, which we like to call the right to work with dignity, because in this country you can't even say right to work anymore, because that's sort of been co-opted by the conservatives. So the right to work with dignity is really determined here by market forces that dictate wages, that dictate workplace conditions, and economic and employment policies respond to the market, which is dominated by large corporations. There is no national employment strategy, let alone a strategy for full employment. The corporations get away with treating workers as a commodity, and government policies distribute money to those corporations without actually regulating or monitoring them properly, including in the high violations industries such as agriculture. And now, as we all know, corporations are also deemed rights holders, and increasingly so with all the with all the new laws coming down. So we have less and less accountability for corporations in this country, with a very detrimental effect on our health. Workers face exploitation at work and lack of meaningful work. There is a stress of unemployment, clearly, but there's also the stress and the unmet needs and the hardship caused through low wages or no wages. And then even on the flip side, for consumers, we have eroding consumer protections due to the rights and powers of corporations. If we move to the human right to Social Security or social protection, in this country, to secure the resources that we need to live a life with dignity is really treated mainly as an individual responsibility that we need to exercise in the market. And current austerity policies that make budget cuts to all the public programs we still did have really exacerbate this. Also, that the social protection programs such as pensions and also health insurance increasingly require people to carry more of the risk themselves and really receive that protection, as it were, in the market. Also, if we look at the public expenditures, they actually fail to do what a proper social safety net is supposed to do, which is to redistribute resources to the poor, but actually the opposite is taking place. The most public expenditures go to the upper middle class in terms of the mortgage interest tax deduction, in terms of tax deductions for employer-sponsored health care, and all these other tax expenditures. And then we also have an actual privatization of the service administration and delivery, for example, of the TANF benefits. Health outcomes, again, we all know poverty is correlated with poor health outcomes. That ranges from all the unmet needs that people face to just the permanent state of insecurity. That ranges from problems related to inequities which manifest themselves at a psychological level as well. So this is all a pretty dire picture. I will end with the human right to food and water. Again, you can predict now what I'm going to say. Food is treated as a market commodity in this country. The subsidies go to corporate agriculture, not toward eating healthy food or producing healthy food. And we have a charity model of food stamps that is subject to eligibility testing. That is not a universal public program. We have also actually the privatization of water supply, which increases people's dependency on investor-owned water utilities. And clearly, healthy food and clean water are directly causing or directly correlating with health outcomes. We have record numbers of people receiving food stamps. We have actually people going hungry. And on the other side of the scale, we have obesity, which is directly linked to the different determinants of poverty and to how the food industry works. And inequality in general and access to food and water is increasing. So this is my very quick sort of run through of what I think the market does to our health. And I feel like this enables us to make a case that the reliance on the market is a structural cause of poor health outcomes, and that the privatization of the core public functions that affect our human rights actually undermines accountability to human rights. And for those of us who really still feel like human rights are silent when it comes to private or public or the market, I would like to argue that human rights are not silent when it comes to excluding, marginalizing, criminalizing people. They're not silent when it comes to the concentration of power, and they're not silent when it comes to meeting people's fundamental human needs. So I think we can make a very good case that the core goods, services, and infrastructure that are necessary to meet people's fundamental needs and that are necessary to fulfill our rights must be treated as public goods and not as commodities. So let's look at, what would that world look like? Just a very abstract sort of vision that we can all fill in. And I said at the beginning, I work with grassroots groups that are, articulating these visions, that are fighting for that. What if healthcare and education and housing and food and water were actually treated as public goods? And what if social protection was universal and guaranteed for all? And what if we placed human rights conditions on all jobs and created public and community-led jobs for the common good? So these just are sort of a very broad picture of what a lot of groups in this country are now sort of working towards, what they're thinking about. They're applying human rights principles to this, and they're developing a policy agenda from this analysis. So if we look at the human rights principles that many groups across this country are now starting to use, they're starting to come together into a human rights movement around the principles of equity, universality, and participation. And if you see those principles in conjunction with this idea of public goods, then you see how it could fit, or how it does fit, with these very basic human rights principles. So if you think about equity, then it is really that essential goods and services must be provided collectively in an equitable way and not according to the market imperatives that exclude people. And if you think about universality, the provision of public goods really must be shared by all and serve the people's and serve the purpose of meeting everyone's needs, and not to make a profit or any other purpose. And when it comes to participation, a key human rights principle, along with accountability and transparency, all those principles of what a true democracy should look like. Of course, communities should be involved in making decisions about public goods, about how these are financed, managed, and distributed. We don't want to go back to a status model as to where everything goes from top down. That is not the kind of provision of public goods we have in mind. This is a community-driven agenda. So when we look at making some of these points a bit more operational, what are groups now coming up with? How is this policy agenda for public goods emerging? I think the first point is sort of a negative demand, which is like stop funding those market approaches that have failed to meet needs. That includes all kinds of forms of privatization and some of these examples I gave. Secondly, and that is also related to the human rights budgeting I mentioned that's currently being advocated for in Vermont, we need to mobilize and distribute public funds and public resources equitably with the goal of meeting people's needs. And we need to provide equal access to universal public goods. And finally, we need to find better ways of holding private corporations accountable for protecting human rights. So as I said, we're using a human rights framework to build a unified movement. And the first step that people take is really they realize that their human rights are being denied, and they realize that their experience is not accidental or isolated. And that's why we place that much emphasis on looking at all the rights together and see how they interconnect, and looking at the structural causes that unite all of those. And we use human rights principles, and those groups use human rights principles in a variety of ways. Most of all, it's sort of a compass, an ethical compass for unifying the movement. It is also a framework for policy demands, and of course, as I showed, it can be a tool for analyzing structural causes and systemic solutions. So thank you very much for allowing me to give this.
So I'll ask our panelists to join me up here again. We promised everyone an opportunity at the end for a little time of comments and questions for our panelists. We're going to deliver on that. Thank you very much for those powerful presentations, interesting and varied in their perspective. So we are going to open the floor for your comments and questions. We'd like to build a little community here as we do that, so I'd ask that you, with your comment or question, identify yourself and say where you're coming from. And comments and questions are both entirely welcomed and encouraged, but we ask that you keep them brief so that everybody has an opportunity to say what they'd like to say. So I think we have a couple people with microphones if we think we need them. But I know there are voices in this room that can certainly fill this space. So please. Who's got something they'd like to say? I have one over here. Hope.
Thank you, and thanks to the panelists and all the organizers of this event. It's really wonderful to hear all of this, even with the bad news that's contained there. I wonder about two issues. One is discrimination or anti-discrimination, which, as you know, is relevant both to the civil political covenant and the economic, social, and cultural covenant. So discrimination in terms of identity, race, ethnicity, gender, sex, disability, LGBT status, etc. And if you're seeing disparities with regard to these social determinants of health. And secondly, to raise the specific question of the disabled population. Because, as you know, there is a Convention on the Rights of Persons with Disabilities. It tries to take a unified, interdependent approach to civil, political, economic, social issues without necessarily using a health model. It's moved to a social model as opposed to, people with disabilities being an object of health and health care and charity, as opposed to members of society that are should have access to all of these rights. Sorry, that wasn't short, but thank you.
Could you just say who you were? Who you are?
Oh, who am I? Hope Lewis, a professor at Northeastern.
Anybody want to respond to that? First, on the issue of discrimination and its importance in this discussion. I guess nobody.
I mean, I think it's very important, and discrimination is obviously a social determinant of health, and my thoughts about social capital are that it could be very helpful if we think about the importance of addressing social networks. And I'm not sure I really understood the second point, Hope.
Yeah, thanks, Hope. I can sort of just speak from the perspective of the groups that I'm working with. And the folks in Vermont have formed strong alliances with the disability rights community. And those folks advocating for the rights of people with disabilities actually feel very much in line with a broader, more cross-cutting, more structural ask around a human rights-based budget, because I think they see, more so even than some other communities, the cross-cutting way of all the social determinants of health. So they are actually amongst the foremost groups now advocating for a rights-based budget, looking at austerity policies, impacts, and looking at the whole spectrum of the services that their communities need. And I think it's great that they're part, an integral part of this multi-issue, multi-community movement there. So I feel like actually they're at the center of that, because they have such a cross-cutting view of the problem.
Thanks.
Robin Tyler from Roger Williams Law School in Rhode Island. This is really a question for Anya, but for others who would like to jump in. I'm really interested in, given our federal dialogue, whether you think that state efforts like the one that's taking place in Vermont is really a good place to start, because it doesn't seem very helpful at the federal level.
Yeah, that's a fair question. To be honest, when I first started working in Vermont, especially, I've worked in other states too, but especially in Vermont, I thought, gee, that's not very promising. Nobody's going to pay attention to that. I mean, Vermont's always been progressive, always led and everything. But as I, over the years, as I continued working there, and we're having successes there, and developing new, model legislation, models of advocacy, it occurred to me that what we're doing there is actually quite similar to what the right wing is doing in states like Arizona or Florida or something. Using the state as a laboratory and really, trying things there, testing it, and then try to cascade it out and get other groups involved. And I feel like we're actually on the verge now of being able to do that quite successfully through the healthcare success, but now also through a broader economic and social rights agenda. Because groups elsewhere are paying attention. We're not yet at the level where policymakers elsewhere are paying attention, but it is about building the movement outward from the state that is most likely to test it, to pilot it, to serve as a laboratory. So I think it could work.
Thank you. I want to follow up on that question. This is Tanya, but inspired in part by Patricia said. Patricia talked about some of the conflict between solidarity and monopoly, and you talked about the importance of human rights and non-discrimination and all these universal human rights, but at the same time working with small groups. But your last comment about right-wing groups and what's going on in Arizona, I guess, raises for me that tension, right? That when we're talking about bottom-up groups and grassroots activity, they are more likely than not, I think, in this country, at this historical moment, to be pushing for market-based reforms or pushing certainly for austerity budgets, right? We've seen certainly, the Tea Party, the taxpayer revolt going all the way back into the 1970s. So I just wonder if you could talk about that tension, because solidarity groups, coalition groups, populist groups, groups that are politically active are often actually wanting to go in policy directions that seem quite distinctly different, divergent from those who are advocating.
Can you say who you are before we get to
Oh, sorry. Wendy Permit, professor here.
Patricia,
Any thoughts about that one, Patricia?
Well, I think, one problem that's been pointed out about social capital is that you can have, some groups that have abundant social capital. It might be, for example, the Ku Klux Klan. And, so people have said to me, well, how could that be ethical? And I think, many moral concepts can be used for both good and bad. I mean, we have liberty is often used also for bad, but that doesn't necessarily take away from the moral quality of it. So, and I think when we actually treat social capital, at least as a moral concept, or solidarity, social cohesion, and then we have this requirement of impartiality that addresses some of those concerns, because if the Ku Klux Klan are not acting impartially, they're acting very partially. So that's one of the benefits, I think, of the ethical dimension.
Anybody want to add anything to that?
I think it's a big challenge, right? I mean, our politics is almost all identity politics now. So everyone has their own groups and their own special interest groups, and we expect that. I'm the biggest fan of solidarity as anyone, but I just don't see it in the United States at all. It's never been an American value. It should be. I'd like it to be. But I still think actually human rights has more of a chance to make it in America as an overall framework than solidarity does. Because at least human rights is American. We may not practice it, but we certainly preach it. And I think once you start preaching it, eventually you're going to have... Words matter. Eventually it's going to it's going to take.
I mean, I would just add that it is always about struggle, right? There's always people struggling for something else, so it is a struggle. But I feel like with human rights, we have an incredible, valuable framework and tool that speaks directly to the people most impacted by human rights violations. So those people will be using human rights. It's really hard to co-opt human rights, actually,
Yep.
and so I think it's a great unifier, and it is something that really has already unified and will unify groups further who are struggling. And there is quite a movement out there already struggling for human rights. It's just, it's out at the grassroots. It's not in the media. It's not an everyday conversation. But there is quite some momentum there, and I'm actually more hopeful.
We have this gentleman here. Somebody got a mic?
I think I can probably do it without the mic.
Good.
I had a question for Patricia, but I think it also relates actually to the question that was just asked about. I was really attracted to the notion of, I guess I should say who I am. I'm Govind Prasad. I'm a JD PhD student at Stanford. I'm from the Commons. And I was curious, I was attracted to the notion of thinking about this right as a solidarity right, but I also was struck by a possible tension between the solidarity right and the human right when I was thinking about your last four proposals. So thinking about the brain drain or including folks who are immigrants into a country where the health system in that country, it seems like part of that is being driven by the idea that people should be included. When I thought about all those four proposals, I thought people should be included in the community. And then my question, I guess for you and coming back to some of the other questions is, it seems like often social capital is really effectively built in smaller communities than the sort of international community, and yet human rights seem like the natural community you're thinking about is this very large international scale level. So how do you, I guess, think about this human right to health in the context of solidarity rights that are often sort of most effectively, it seems like, realized for these very local, sort of partial communities?
That seems like a lot of questions to me. Well, I mean, one question, as I understand it, is how can you have global social capital? Is that one question? I mean, I think that the internet facilitates that, and transit facilitates that. I think demographic changes are going to facilitate that as people, identify less with their own groups and with homogeneous groups. People just travel more. I mean, I think, I think it will just come to some extent. And, as I suggested, when we actually look at the definition of social capital and we apply that to the global context, it seems to exist. There have been some studies done on international social capital, not very many, but there have been some. And one of the things that they've shown is that you see it especially with immigration flows, people moving to new countries, that what they do is they sort of take their social capital from their home countries, bring it back, but then they also create these new groups in their new country, and apparently having the social capital with your original country actually helps to build, so you don't have to make these trade-offs. Apparently there's no trade-off to be made. So, I mean, I'm optimistic, but, I'm kind of a social capital person, so I'm optimistic about that. And now the second question again, can you just say again, please?
I was just curious about when you talk about impartiality, it seems like often the institutions that build social capital involve a sort of partiality to people inside your community. It's the idea that doctors should help people in their community instead of being part of the brain drain. You should help immigrants to your country in ways you shouldn't necessarily extend universal health care to people, your national health care system folks in other countries. It seems like it involves partiality, so I wonder about the tension between.
Yeah. Yes. Well, I mean, I think that many people who leave, many medical workers who leave their home countries do so because, financial lures, and also because of educational opportunities, because of the system is better systems, so there more money, sending remittances back. So, I mean, in some ways there is this ideal way it can benefit both countries. But it has to be compensated for so that the original country isn't harmed by it. I mean, so it seems to me that the notion of sort of global social capital can accommodate that, because what it does is it encourages us to build these ties impartially. Is that helpful? Oh, good.
Probably one or two more I think we can do. You want a mic or you want
I'm Abby Alexander. I'm getting a master's in organic chemistry in the College of Science, and I was just wondering if the right to health and cultural rights are both human rights. How can you necessarily implement health rights if they go directly against cultural rights? In such a case as, for example, I was reading, I think, about a case in sub-Saharan Africa where a woman had complications during childbirth and had to have a hysterectomy, and then her husband demanded a repayment from the doctor in goats because she could no longer bear children.
Okay. What you say about South Africa? Well, in Mexico, we constantly have to work with those kind of subjects because, for example, it's very often that in some regions of the country, women cannot go to the doctor if they don't ask permission to the husband or to the man in the house. So if they are pregnant and they want to go to the doctor, they cannot do that by themselves. So that's one of the hardest part to work, and I think that the work, even though it's different, the part of the right in our Constitution says the right to health protection, and sometimes when the government is trying to give this, what we have to do is to start making like very big programs of sensibilization, of the trying to change a little bit of those cultural things. And sometimes what we are doing in special places like in the Southeast is that we have to recognize and accept all the cultural things, and we say, okay, that part is good. No, it's good that you do this or that practice that can help, but this other one, just by like trying to educate people, because I don't think you have another alternative when it's something cultural, because if they go to the doctor without the permission, it's, you know, the consequences are really horrible for them.
Way up in the back, please.
Thank you all. And I was making connections across many of the talks. I'm happy to be on school social work at the University of Connecticut. And my question seems maybe more directed to Anya because it's such a profound challenge, this notion of tackling the market-based approach to so many elements of this particular society. And so I wondered if you could comment just a bit further on the way in which the groups you work with struggle to change cultural norms and values. So to struggle against, say, extreme individualism, or the sense that the private, you know, the tax expenditure you get for your property is your right as a homeowner, versus what those resources might be able to be used for in a broader, more public goods framework. And I just think, you know, Connecticut just down the way, you know, more than 20 years ago, court case decision, Sheff versus O'Neill, really arguing for a much more equitable system of education and to grapple with pretty radical racial discrimination and residential discrimination. 20 years on, our outcomes are worse, even after that landmark ruling. So it seems that there needs to be much more of the grassroots cultural shift if we're going to come to a place where even, you know, the laws that we, you know, the rulings or the laws or the policies we pass actually get implemented.
Thanks, Kathy. I think that's exactly right. I mean, it's very well put. That it's a huge challenge, and we're trying to grapple with that in Vermont, but really by building it from the ground up, by really doing the organizing, getting people to tell their stories, getting people to talk to their neighbors. So it really, there's probably not a shortcut to that. So when I talk about the human rights budget, or we call it the People's Budget campaign in Vermont, it's about a year and a half old, and it's still at the very beginning, even though at the policy level we've already had some success, but before you get the notion sort of imprinted into people's hearts and minds that really, it is the purpose of a budget to meet people's needs, and it is not the purpose of the budget to manage to the money and to first look at, oh, here I have a revenue forecast, so therefore this is what I have to cut this year. That's not the purpose as to why we have government. That is a huge paradigm shift that we're aiming for, and we're being quite explicit about that. We're talking to people about, look, we're doing something completely different. We're moving from managing to the money that happens to be available on the books to managing to people's actual needs, and that involves an entire shift. And the way the way that's sort of being communicated is through people's stories of unmet need. And a lot of people have unmet needs. I mean, that's really what's, sadly enough, what's on our side, that almost everybody has a story of how they feel that they can't live the way they would want to live, or the way they would want to see their community develop. So it is a matter of getting enough voices together and then connecting the dots and seeing, well, wait a minute, there's actually something wrong at the level of government, and we need to change the way government operates. But yeah, it's going to be a long slog, I think.
Thank you very much. Well, Sabrina, do you have we're going to move on quickly, but do you have one more? You sure? Yeah. You'll have an opportunity. There's another session coming, and I'm sure you'll have an opportunity to raise that same question. So thank you. We are very shortly going to break for about 15 minutes so that you can all get a cup of coffee and rejuvenate yourselves or get a little something to eat outside. Before we do that, I first want to appreciate the panelists in this first panel. So thank you all.
Thank you.
Thank all of you for your attention and your participation as well. I also want to introduce Mariah McGill, who's the Associate Director of Fergie, who's going to make a short presentation.
Good afternoon. I just want to briefly recognize Govind Prasad, the 2012 Student Writing Competition winner. Each year, Fergie holds an annual writing competition to coincide with this institute. The competition is open to law students and youth graduates from around the country, and the winning author is invited to participate in the events of the institute. So we're delighted to publicly recognize Govind. He is a JD PhD student at Stanford. He is currently working on a dissertation project on socioeconomic mobility and theories of justice. He was a 2011-2012 Center for Law and Biosciences student fellow at Stanford Law School. Before law school, he was a predoctoral fellow from 2006 to 2008 at the Department of Bioethics at the National Institutes of Health. Govind's article is entitled "The Right to Health: From Maximization to Adequacy," and in it he argues that the right to health should be understood as the right to adequate health, rather than the right to the highest attainable standard of health as is currently defined by the International Covenant on Social, Economic, and Cultural Rights. While his project is a critical one in that it uncovers and highlights problems with our current understanding of the right to health, he does not reject that right. Rather, he agrees with the ESCR drafters that the right to health is an important right, but argues that it needs to be reconceived so as to place it on par with rather than above other important rights. His thought-provoking paper is available on our website, so if folks are interested, you can go there. So without further ado, I'd like to call Govind up and officially bestow the 2012.
Hi, good afternoon again. I'm Wendy Parmet, and I want to welcome you back to the second part of this afternoon. And before I introduce, and I have the great honor of introducing our speaker, I want to first say a word about the Program on Health Policy and Law, which along with Fergie is sponsoring this institute. The Program on Health Policy and Law is an interdisciplinary program bringing together people from across the Northeastern University community to explore and dialogue about issues relating to health law and policy, from the U.S. healthcare system to global public health. We are a diverse group. We sponsor lectures, programs, panels, student events, and faculty colloquia and research and interdisciplinary research for faculty. And we are thrilled to be working with Fergie in partnership to bring this event. I also want to thank Kevin Murray, since he was thanking everybody, but he has done an extraordinary job in organizing this event and bringing it together. So thank you so much, Kevin. It is a great honor for me to have the pleasure of introducing Dr. Ichiro Kawachi, who truly is one of my intellectual heroes. I think I'm sure he doesn't know this, but your name probably appears in the footnotes of my book more than anyone else's. A world-renowned leader in social epidemiology. Dr. Kawachi is professor of social epidemiology and chair of the Department of Society, Human Development, and Health at the Harvard School of Public Health. He received both his medical degrees and a PhD in epidemiology from the University of Otago, I hope I pronounced that right, New Zealand. And he has published hundreds of papers on social and economic determinants of health and explored the role that inequality and social capital and neighborhood level issues play in determining population health. With Lisa Berkman, he co-edited the first textbook on social epidemiology, named Social Epidemiology, published in 2000 by Oxford University Press. He has also co-authored numerous other books, including The Health of Nations, written with Bruce Kennedy, and published by New Press in 2002, and Globalization and Health, written with Sarah Wamala, and also published by Oxford University Press in 2006. He is the senior editor of the journal Social Epidemiology, the co-director of the Robert Wood Johnson Foundation Health and Society Scholars Program, and an elected member of both the Institutes of Medicine and the National Academy of Sciences. It is very fitting and a deep privilege to have him present our keynote address for this institute, which is dedicated to exploring the intersections of human rights and the social determinants of health. He has led the way for understanding these issues throughout his career, and I am thrilled that he will be speaking with us this afternoon.
Thank you very much, Wendy, for the kind introduction, and it's a great pleasure to be here. I'm going to spend the next 45, 50 minutes making the case for the social determinants of health from a social epidemiological perspective, and I hope to keep my remarks. I have to confess I don't know a lot about the health and human rights side of things, and I hope that my remarks will stimulate some question and answers and a bit of debate. So, in broad outline, I'm going to try to make the case for why social determinants of health matter. I'm going to give my 2 cents worth on why it's so hard to get action on the social determinants of health, and then also provide some indications of what I think are the best buys in social determinants of health for practitioners who want to act on the kind of things that I'm going to talk about. All right, so I think the starting point for making a case about social determinants of health, for me, comes from this distinction that we make between upstream and downstream determinants of health. I was trained as a physician originally, and then I came into public health. And you can imagine there are very distinct modes of thinking in the two professions, and it took me a long time to realize what it was that I was doing in public health that was different from how I acted on a daily basis in clinical medicine. And just out of interest, how many people have heard this distinction between upstream and downstream determinants. Quite a few. Many people have heard of it, but not many people know its origins. As far as I know, the origin of this metaphor comes from John McKinley's essay on a case for focusing upstream, in which he was the first to describe this. John's actually a fellow New Zealander and medical sociologist, and he was describing in this essay how his clinician friend described the practice of medicine, how it felt like to him as he practiced medicine on a daily basis in his local emergency room. And this is a quote from his friend as recounted by McKinley, that the clinician says, "It feels like this, that I am standing by the shore of a swiftly flowing river when I hear the cry of a drowning man. So I jump into the river and I pull him to shore and begin artificial respiration. Now, just when he begins to breathe, there's another cry for help. So I jump into the river and I reach him, I pull him to shore, I apply CPR, and just as he begins to breathe, there's another cry for help. So back in the river again, and then another yell, again and again. And I'm so busy jumping in and rescuing them that I had no time to see who the hell was upstream pushing them all in." That, as far as I know, is the origin of this upstream-downstream metaphor. And I must say, in harking back on my own career, that's exactly the sensation of doing medicine on a daily basis. You're treating people who come into the emergency room, you bandage them up, you patch them up, and then you send them back into the original conditions which led them to become ill in the first place. So it's very much of a downstream kind of practice, whereas in public health, I dare say what we're trying to do is to paddle upstream. And to illustrate this kind of metaphorical thinking, I want to give a worked example for the case of obesity, how we might think about addressing the problem of obesity as in an upstream-downstream kind of framework. So as clinicians, we're focused downstream, which is closest to the level of intervening on individuals. If you're a clinician, you have one-to-one practice in your daily clinic, counseling patients how to modify their diet to increase their physical activity levels, perhaps counseling them about their genetic risks and so forth. That's what certainly I used to do as a clinician. But then the practice of epidemiology, and particularly of social epidemiology, is to change the focus of intervention more upstream. And so individuals are embedded in the different kinds of residential neighborhoods, which are characterized, at least in terms of dimensions such as the built environment, the quality of the built environment, and that if we take it even further upstream, the built environment itself is a reflection of societal decisions about transport policy, urban planning, and so on. So really the practice of public health, but also of social epidemiology, is about focusing upstream to these ultimate drivers of population health patterns. And if you think about this transport policy and urban planning part of it, there are many things in life that we take for granted, but which are actually societal drivers of sedentarism, the extent to which we get our exercise and so forth. To give a simple example, the American society is very much car-oriented. That if we look at decisions that are made at the planning level, many things conspire to produce automobile reliance, and that's true of. Most obviously, it's true when we have fast food outlets that are designed so that we can place our order and get our French fry fix without even getting out of the car to get the 10 steps of physical activity. This is really American. The drive-through is a U.S. invention. There are many. I've been to McDonald's all over the world, and this is a uniquely American phenomenon. But that's really just the tip of it, isn't it? This just happens to combine eating junk food with sedentarism, but the automobile reliance in American society extends to the way we do our banking, drive-through ATM machines, drive-through prescription pickups. These are, all features. If you step outside the United States context, they don't exist in other societies which don't emphasize automobile reliance to the same extent. The U.S. Government has designed post boxes that are especially designed for people who don't want to park the car and walk the 10 steps to post a letter. You can do it from the car with these specially designed intake boxes. Whereas when we look to other societies, they do quite the opposite. If you recall the New York Times of last year, it was, the story I thought was very interesting was headed across Europe. Irking drivers is urban policy. So the start of the story, which I quote here, whilst American cities are doing everything like synchronizing green lights to improve traffic flow, offering mobile applications to help drivers find parking, a lot of European cities do exactly the opposite. They create environments. Oh, sorry.
You bet.
I can keep reading that stuff.
It's been on too long, and it hibernates, and he likes hibernation. This is what I do in class. No, don't shut down. So sorry.
That's all right. I can see the screen here, so I'm going to keep reading for you. This is perfect because then you can listen to my reading this story. So the Time story was saying that a lot of European cities are designed to do exactly the opposite. They create environments that are openly hostile to cars. The methods vary, but their mission is clear, which is to make car use both expensive and just plain miserable enough to tilt drivers toward more environmentally friendly modes of transportation. So the content of the story was really about trying to encourage environmentally sustainable modes of transportation, but in fact these have public health implications as well. And this is just a small example, but if we consider investments of different societies into public forms of transport, that America does very little relative to most other industrialized countries, or that what proportion of the government budget is devoted to building public transport infrastructure. For example, in the Omnibus Act passed by U.S. Congress once every while to invest in transport infrastructure, and 98% of that budget, billion-dollar budget, is devoted to building of highways, improvement of motorized infrastructure, building bridges and highways, and a tiny, tiny proportion to improving the walkability of neighborhoods, providing bike paths, or even building railroads, for example. It really is a pattern that is flipped from most other countries that emphasize transport policy in order to build sustainable environments and encourage physical activity. You can't see it here, but the other side of the flip side of obesity from a social determinants perspective. So, built environment is the energy out side of the equation. Built environments encourage physical activity and hence calories out. But there's also the calorie in side of obesity, which is what we call the food environment. So if we go upstream from individuals who are either able to restrain their caloric intake or not, we might consider to focus upstream and think about their food environment, and the food environment itself. Whether you have supermarkets nearby that retail fresh fruits and vegetables, or whether your neighborhood is surrounded by fast food outlets. These things are really reflections of societal decision making about food production, marketing, and distribution. And you can't see this either, but the point I just made is after all the message of Professor Marion Nestle's book, Food Politics, which many of you, I'm sure, have come across. She argues exactly what I just said, which is that our food habits, our nutrition and diet are really reflections of national politics. And and the story she gives us, why is there a book called Food Politics? What's politics got to do with nutrition? And the example she gives is that in this country, nutritional advice has remained unchanged for half a century. Let's see if we can get this beautiful. Take a minute. Oh, okay, yeah. So I can keep talking. Yeah. So if you've read Nestle's book, she says nutritional advice. She points out that nutritional advice in this country has remained unchanged for over half a century. If you go back to Ancel Keys, who in the 1950s, as early as then, had only two pieces of advice for the American nation. Number one is all of us should eat less, and number two, we should eat more vegetables. It's a very simple. You only need to know those two things. Thank you. Yeah. So those are the only two things you need to know about diet. I mean, it's hard to believe, given the proliferation of many kinds of dietary advice that seem to, obfuscate the issue. We always have one new fad diet coming online on a monthly basis, whether it's Atkins or the Cro-Magnon diet or whatever it is. But the only two things you need to know from a public health perspective is you need to eat less and eat more vegetables. And as Nestle says, what's the problem? Why is it so difficult to get this, these two pieces of advice out to the community? And one obvious reason is because the food industry has become so efficient that it produces sufficient calories on a daily basis to feed the entire U.S. population twice over. So there's overproduction, and they have to somehow get it out there to clear the shelves. And so we have a situation of two contrasting advice. Our advice: everyone should eat less. Food industry advice is we should eat more, twice as much, in fact, as we probably need to. And that advice, based on Dr. Nestle's analysis, is transmitted through the food industry influence on subsidies, television marketing, nutritional misinformation to consumers, etc. That's basically the social determinant story of obesity. And accordingly, if you want to target the upstream strategies to reduce the obesity problem, we have 2 or 3 simple principles. Number one is, all of our strategies should focus on those who are producing the epidemic rather than people doing the consuming. An example of which is empowering, the Federal Trade Commission to regulate food advertising as opposed to leaving it to voluntary agreements. Paying attention to curing the environment as opposed to the individuals. So this is the distinction between medicine versus public health. And just as an example, that might be greater use of zoning restrictions to keep noxious businesses out of harm's way. For example, outside of our school zones. And then becoming more intersectoral, that is, not leaving medicine just to the health professionals, but taking seriously the Rudolf Virchow's adage that all medicine is politics, and politics itself is nothing more than medicine on a grand scale. And it really, this is just an expression of the idea that all kinds of policies are, in the end, health policies. It's not just, when we think about health policy, I think the assumption in the public's eye is that the extent of health policy is about health care policy, such as, who shall get coverage and access to health care and so forth. But really, the major drivers of health are non-health policies in the way that I'm talking about. That it's really to do with housing policy, transport policy, education. I mean, all of these are major social determinants, far more so than what doctors can do on a one-on-one basis. We have a tendency to equate medicine with health improvement, because we see the doctor when we're sick, and the doctor is very, very effective at patching you up. But the real drivers of health, 90% of health is really determined by what happens before you get to the doctor's office in the first place. And accordingly, the drivers of health are non-health policies. They're economic policies, housing, immigration, education. I think that's where probably I have much in common with people in the Health and Human Rights Institute. All right, so having made that philosophical case, I have to admit it's very difficult to get to make the needle move in either political decision making or in public discourse. Social determinants is a very difficult message to get across, for the reason that same reason that I experienced by retiring from clinical medicine and moving to public health. In a word, what happened to me was one day I was doing the stuff on the left-hand side, which is heroically saving people based on the interventions I was doing directly, versus when I switched to public health, what I do instead seems much more pallid by comparison. In the left-hand side, I could literally point my finger and name the names of people whose lives I saved that day or any other day. They were identifiable beneficiaries. Whereas when I switch to public health and move upstream, I'm doing stuff like pasting non-smoking signs in hospital corridors, which I really can't tell whose lives I've saved. One huge problem with social determinants is that the left-hand side seems infinitely more sexy compared to the stuff that I'm doing on the right-hand side. Now, there's a bit of evidence from fields of psychology and behavioral economics why that may be the case. And I want to illustrate the challenge we face with this example of a study by Deborah Small and George Lowenstein and Paul Slovic, well-known behavioral economists, who demonstrated the problem that people have in empathizing with an identifiable victim versus a statistical victim. Their starting point was that often when donating to charitable causes, people don't tend to value lives consistently. Money is, often concentrated on a single victim, even though many more people would be saved if resources were dispersed. So they set out to show this on an experiment on 120 subjects who were filled to ask an irrelevant survey. I don't remember what it was about, but in any case, this was a decoy. The true meat of the experiment was that after taking the survey, the subjects received $5 in compensation, accompanied by a charity request letter that informed them of the opportunity to donate to Save the Children. So you see, you get $5 and then you get an immediate charity request letter. Now, the part of the experiment was this. The people in the experiment were randomized to one of three conditions. 1/3 of the group, on the basis of a coin toss, received an identifiable victim script, which I shall call the poster child script. Another one received a script that described a statistical victims, and then a third group got a double whammy. They received both the identifiable victim and the statistical script. The identifiable victim script looked like this, a picture of an identifiable individual who could be saved as a result of your intervention. And the script, basically said any money that you donate will go to Rokia, who's a 7-year-old girl from Mali. She's desperately poor and faces a threat of severe hunger or even starvation. Her life will be changed for the better as a result of your gift. And with your support and other sponsors, Save the Children will work with Rokia's family and other members to feed her, provide her with education, basic medical care, and hygiene education. So this is the identifiable beneficiary script. Now, those who got the statistical script received a script that described a far more horrendous situation in numerical terms. They said food shortage in Malawi affecting more than 3 million children. Zambia, severe rainfall deficits resulted in a 42% drop in maize production, and 3 million Zambians face hunger. 4 million Angolans, 1/3 of the population, have been forced to flee their homes, and more than 11 million people in Ethiopia need immediate food assistance. So if you imagine yourself being in this experiment, which do you think you would have given more money to? The identifiable beneficiary script, or this script, in which describes problems that are many orders of magnitude more severe compared to the identifiable victim script? The answer is the identifiable victim script wins hands down. Basically, when people we're trying to solicit donations, you have to really focus on an identifiable individual, and that's the group that wins. Now, the question is, what do you think happens? Remember that this is an experiment which had 3 arms, so a third group received both the statistical and the identifiable victim script. And what would you think happened to that group? I mean, if we think logically about this, people received a double whammy of the identifiable story and the statistical victim. You think that receiving both should give rise to the biggest donations? You're shaking your head. Why? Huh?
No, the problem I have with this study is that the statistical victim
story
is so overwhelming.
Yes.
The message that you get is, why bother to give?
Right. Yes. Yeah. No, very, very interestingly, so let me come back to that point. No, so rather than combining, getting the double whammy and both the stories, actually, if you mess up the identifiable victim script with the statistical script, you end up with a lower level of donation. Actually, one interpretation, exactly as you said, that there's millions and millions, and so there's a drop in the bucket effect. People think, oh, why should I bother to do this? Because any money that I can donate couldn't possibly make a difference to that individual. Well, actually, these researchers have done additional variations on the experiment, which instead of the millions and millions script, they show 2 victims and 3 victims instead of 1. They still give less. It's very distressing. And it isn't that these people, when people see that, they aren't dividing the $5 they could give by 3. Because it's in this experiment, different people receive different stories. So there really does seem to be something about focusing away from the single identifiable beneficiary or victim toward some number that's greater than 1. Anyway, I think this for me provides an insight into why public health ends up being the orphan of clinical medicine, why upstream social determinants ends up being as in this case, less than 3% of U.S. healthcare expenditures. A $2.3 trillion budget. The lion's share goes to personal care services, whether it's hospitals, physicians, drugs, and that's one huge challenge we confront in trying to get people on board or moving the needle on prevention. And trying to get people to focus on the importance of statistical beneficiaries. I mean, in my example that I gave earlier, there's a huge, there's a very persuasive thing to save individuals on a daily basis and to be able to name them and point to them. And yet the number of lives saved by doing that is in the end going to be less than for example, being able to pass some legislation that would restrict smoking in public places, for example. The statistical beneficiaries are potentially far larger, but they're not as persuasive as the identifiable beneficiaries. I've already mentioned the other barriers being the conflation of health and healthcare. Most people think because healthcare is able to save lives, that therefore that's the determinants of health. So you're conflating the treatment for health problems with the cause of the problem. The timing of costs and benefits of action separated much more in prevention and upstream interventions than in clinical medicine. In open heart surgery, within a couple of hours, you're presumably saving someone's lives. If you pass legislation to restrict smoking in public places, that we have to wait a while until those lives are saved. And then I think lastly, there's often a conflict between individual responsibility versus a constrained choice. That is social determinants, which tends to emphasize constrained choice and how we have to do something to try to encourage people to behave in more self-interested ways. And all of these, I think I should add a fifth one, which is that in the prevention kind of lingo, the benefits will often fall outside the political cycle, so politicians have relatively little incentive to invest in things where the benefits will fall outside their timeline of getting re-elected. So I'm not trying to downplay the many challenges that we confront. Having said that, I think I want to devote the rest of the time in describing what I think the most promising best buys in the social determinants of health, that given limited resources, if we had to invest somewhere, where would we do it? Now, I know that Sir Michael Marmot was supposed to speak at this conference, but he had an unfortunate accident. Had he been here, I'm sure he would have shown the slide on the World Health Organization Commission on the Social Determinants of Health, which he chaired, and the top line, the front page of that commission report was the need to improve daily living conditions, whether it was in making early childhood investments, urban planning, fair employment and decent work, provision of universal health care. I think these are good sets of recommendations. They're not particularly prioritized, but if you were to ask me, of all the social determinants that I've studied, where would I put my investment in? I have a couple of things that I would like to focus on, and that's what I'm going to talk about as a practical matter. I think investing in early education is terribly important. I think preventing the intergenerational transmission of poverty is extremely important, and I'm going to provide some evidence on what we know about policies to do these things. So early education, why is it that I say early education is important? Well, in social epidemiology, we try not to advocate for policies where we don't have very good evidence, preferably from controlled randomized trials, for example. It's very difficult to think of randomized trials of education. They tend to be sparse because of ethical concerns and low feasibility. A randomized trial is really what you'd have to do is to take a group of children and based on the coin toss, say to one group, you shall get extra education, and the other half you'll have to stay home. And it's not often that we would see IRBs approve of that design. But it happens that in the realm of education, there are a couple of historic trials that were literally done in that way. There were randomized trials of preschool interventions, which they got away with in a way because they offered something that was much more enriched than above the local standard of care. And the studies I'm going to describe are the famous high-scope Perry program and the Abecedarian program. These two we have some health information on, which forms a basis for my saying that this is one of the best buys in the social determinants of health. The Perry program basically was an intensive preschool program that was carried out in Ypsilanti, Michigan in the 1960s. They enrolled 120 disadvantaged children. They all happened to be black. That was the profile of disadvantaged kids in that town, who were aged 3 to 4 years. And the treatment, that is the active treatment in this trial, consisted of a daily dose of 2.5 hours of instructions by teachers with a master's degree on weekday mornings, supplemented by a weekly 90-minute home visit by a teacher. So that you either got this if you came up heads, if you came up tails, you just stayed at home and received whatever your parents could arrange for you. They did this, carried this program for 30 weeks a year for a duration of 2 years, and you have to be very patient and outlive your subjects, to do these studies. But these kids have been followed up till age 40. That's one of the other reasons why we don't see many trials like this, because you have to outlive your subjects. The ABC variant program was even more intensive than Ypsilanti. There's an intensive preschool program in Chapel Hill, North Carolina, conducted in the 1970s. They enrolled 111 disadvantaged children. Again, they were all black. This time in North Carolina, they started at an even younger age. At age 4 months, they started getting educational enrichment. And the treatment in this case was 8 hours a day. So you get 4-month-old kids and you educate them for 8 hours a day, and 5 days a week. And they did this for the first 5 years. And they had some additional activities even when they entered elementary school. The duration, I did not misprint. I think other than 2 weeks off, they just got this whole thing for 8 years at 50 weeks per year. So extremely intensive. And I will talk about the cost and cost effectiveness in a bit. They were followed up through to age 21. So that's the two really good, well-described randomized trials we have. Here's the Periscope result of subjects up to age 27. The red bars show the outcomes among the intervention children, the blue in the control group who didn't receive this enrichment. And as you can see, for academic outcomes on the left-hand side, intervention children were much less likely to end up receiving special ed. They're more likely to be in the 10th percentile of academic achievement, and to graduate from high school. They were more likely to be earning more than $2,000 a month at age 27, to own their own home, and never to have been on welfare as an adult. So, these are all just based on that preschool intervention that happened 3 years before these results were recorded. The beauty of randomized trials also is that we can think of, if we were to do this just based on a non-randomized observation, we would all be worried about confounding factors, differences between a child who got special enriched education versus those who didn't. But the beauty of the randomized trial is that it gets rid of all of that worries by just tossing the coin and making sure that all these confounding variables are balanced between the groups. In the ABC variant trial, here's the follow-up to age 21, that they also had were less likely to be receiving special education, to repeat a grade, more likely to graduate from high school or to be enrolled in 4-year college. And here's where some of the health outcomes come in. They're more likely to be non-smoking or to be engaged in skilled jobs or actually be in higher education. There have been some other outcomes, such as they're less likely to be engaging in drug use. They're more likely to be wearing seatbelts. They're less likely to be obese. There's a whole range of health behaviors that are apparently track with something that happened very, very early in life. Now, I'm emphasizing early education as opposed to expanding college education or encouraging people to graduate from high school. I think these educational outcomes are very important, but I think in everything we've learned about in neuroscience and education suggests that early exposure is the most important and critical thing we can do to improve outcomes. And why do I say that? One of the reasons I say that is because of evidence such as how self-regulation, the ability of children to regulate their behavior is formed and observable and formed very early in life. Many people have heard of the famous marshmallow test. I think there was a radio program about this recently. Basically, there's an experiment done by Walter Mischel, who's a psychologist at Stanford. He took a group of 4-year-old children and he led them into a room where they were confronted with their favorite snack, in this case a big, fat, juicy marshmallow, and they were given a delayed gratification task. They were told, you can either eat this marshmallow right away, or you can wait a few minutes while Dr. Mischel left the room to run an errand, and if you can wait until I return, then you can have 2 marshmallows. So this is a self-regulation task. It's really measuring the kid's ability to delay gratification. Do you yield to temptation and have the marshmallow now, or can you wait and double your reward? And I think these are pictures I just pulled off the internet of various YouTube videos of kids trying to delay gratification. It's quite cute watching dude go through this task. Now, the kids were told actually that if they couldn't wait any longer, then there's a bell on the desk next to the marshmallow which you can ring to summon back Dr. Mischel, in which case you can eat the candy right there, but you forfeit the bigger reward. So you can, Mischel gave them instructions, and then they left the room, and then they time how long the kid can delay gratification. And very interestingly, actually very cruelly, Dr. Mischel left the room for up to 15 minutes, which I think seems like an extraordinary high bar, and that, of course, almost nobody lasted 15 minutes. But it turns out there's a very interesting distribution in the way that kids respond. About a quarter caved in within 2 minutes. Never mind 15. They just cave in within 2 minutes. The average child lasts about 6 minutes, and then another 25% lasted more than 10 minutes. So there's a distribution that is reflecting, I think, the distribution of self-regulation in the population. Now, who cares whether that's of any consequence? Maybe marshmallow test. Maybe the kids who skipped breakfast that morning happen to be very hungry, and therefore they're more likely to ring the bell. And perhaps we're just measuring this, this random distribution in the population of personal circumstances. But I think the follow-up papers by Mischel and colleagues suggest otherwise. They recontacted a sample of the original kids when they were 16 to 18 years old, so between 12 to 14 years after the experiment. They were recontacted, and then their parents were grilled regarding their coping styles, their SAT scores, and their health behaviors, and what ability to delay gratification at age 6 is a strong predictor of how the kids were turning out later in life. Kids who succumbed earlier were more likely, their parents were more likely to answer that their child as easily yields to temptation, that they have problems exhibiting self-control. Kids who waited longer had higher SAT and verbal and quantitative scores. The difference is about 171 points on the quantitative and 126 on the verbal scale. That's a huge difference in ability to delay gratification. And I think the implication for a social epidemiologist is that much of health behavior is determined by things like self-regulation. If you think about all the things that public health people like to tell the public to do or not to do, whether it's avoid smoking, drug abuse, don't eat too much, exercise more, floss your teeth, all of these involve self-regulation and the ability to delay gratification. Every one of these problems are problems of what we call intertemporal choice, because the intertemporal choice problems occur when the benefits and costs of behavior fall in different time periods. So all of everything that we counsel the public to do either fall into the category of investment goods or sinful goods. Investment goods are things where we have to, experience pain or some hassle now in order to get benefit later. An example would be flossing your teeth or exercising. They involve some, varying degrees of hassle right now in order to obtain a benefit years into the future. Or they're about avoiding sinful goods, in which the pleasure is now, whether it's reaching out for that next cigarette or reaching out for the Krispy Kreme, and the costs fall years into the future. Now, if behaviors had the characteristic of where the costs and benefits fell at the same time period, let's say smoking the cigarette will lead to immediate death, then we would have no problems whatsoever in getting people to stop. But it's because the benefits and costs fall in different time periods that it's a huge issue. And I would say that much of those behaviors, the ability to delay gratification or conversely to invest for the future, is really a reflection of this patience or self-regulation. And I'm saying that much of that self-regulation is determined by what kind of early education that you receive. There's been some story doing the rounds of a variation on the marshmallow experiment, in which they showed that if the kids are given signals that the experimenter is unreliable, so before you do the marshmallow experiment, the experimenter comes in and promises some things to the kids, like, I'm going to give you some art supplies, and then you violate that trust, therefore signaling to the kids that the world is unreliable and the experimenter is unreliable. If you do that, then it seems like everybody, is quick to cave, But to my way of thinking, that only goes to prove that the self-regulation is contingent. It doesn't show that kids who caved early to begin with, are suddenly able to behave in a more regulated manner when the experiment was shown to be reliable. It doesn't work like that. How it works is that if you show that the environment is unreliable, then everybody caves. That's just a crimp on the. I don't view that as denying the fundamental importance of the pathway I'm showing here. Now, it turns out there's striking agreement between different disciplines about the importance of early investment. This is, I think, a groundbreaking paper in the Proceedings of the National Academy of Sciences, written by a group of people who are about as far apart from each other as you could get. Eric Knudsen studies animal neurological development. He mainly uses owls as his animal model. James Heckman, you might know, is a Nobel Prize winning economist. Judy Cameron's a psychologist. And Jack Shonkoff's an MD, a pediatrician who's in my department. And they reviewed all the economic, biological, and behavioral evidence on the importance of early investment in education, and they concluded that there are 4 concepts that people tunneling from different directions have arrived at. And let me quickly go through these. Concept number 1 from neuroscience is that basically brain maturation and skill development have to happen in a hierarchical process. You cannot neglect children and then come in later on and hope that they will catch up by investing in community college. Basically, skills beget skills. That's the way that the brain is built up. And you can't learn to walk before you learn to crawl. And that tends to suggest that you have to start early in order to set people on the right trajectory. The second concept from developmental psychology is that early experiences have a uniquely powerful influence on the development of cognitive and social skills, as well as on brain architecture. We think in the development of the brain there are sensitive periods or critical periods for optimal acquisition of skills. We know, this is true in the sensory cortex. We know, for example, the development of certain sensory capacities, such as vision, are critically dependent on certain developmental periods. There's some famous experiments in which some psychologists, I think it was a Harvard professor, sewed up the eyes of a newborn kitten. So you can do the experiment where you can sew their eyes shut when they're born, and if you leave it like that for a couple of weeks, even though later on you remove the stitches, they'll never be able to see, because if you miss the 2 weeks of vision, that's it, for the visual cortex. And probably even some higher order functions have that kind of sensitive period. Language acquisition is an excellent example. We know that if you want to speak a language like a native speaker, you have to do it before, preferably before age 13. This shows the English proficiency score of Native Americans, native-born speakers on the left-hand side, who have the highest proficiency, and on all the numbers on the right-hand side are the Asian American immigrants, Chinese and Korean immigrants, according to what was their age when they arrived in the United States. And you can see there that there's a critical period right there. If you arrive in this country between ages 3 and 7, or even before age 10, you can expect to speak English like a native-born individual. But beyond that, the skills rapidly drop off. If you arrive later than that, then you can, no matter how hard you try, your brain is never able to distinguish between the sounds that a native speaker makes versus someone. And there's one reason why. I mean, in Japan, in the Japanese language, L and R's are very, they don't really exist. My father, who learnt English as a PhD student in his 1930s, he's perfectly fluent, but to this day he cannot distinguish between ordering a bowl of rice in a restaurant or ordering a bowl of lice. They sound exactly the same to him. It doesn't sound the same to me because I learnt English when I was about 10 and a half, which is right at the cusp of being able to do this or not. So that's what the developmental psychologists say. In economics, they have come to much the same conclusion, which is early intervention lowers the cost of later investment. You can sort of try as we might to remediate later on. They are less effective and less cost effective. So that includes literacy services, prisoner rehab programs, education programs, all these things for disadvantaged adults. All of these tend to yield lower economic returns than early intervention. And according to James Heckman's work, if you look at the rate of return on investment in human capital, the horizontal line is the opportunity cost of $1 invested in any investment, and you can see that the rate of return is positive. It's above that opportunity cost of funds for preschool programs, but then it declines as you put off education till later ages. It's sort of below the opportunity cost of funds somewhere in elementary school, and then beyond that, it's way below the market rate. Of course, lastly, it's not all over by age 4. If it was, there wouldn't be much for there wouldn't be a whole lot for social epidemiologists to do. But early interventions are still sustained the best when they are followed by high-quality learning experiences. In other words, they must be followed by later investments to recoup maximum value. And the final conclusion of this paper is that the most cost-effective strategy for education is investing in the early environments of children who are disadvantaged, beginning as early in life as possible. And in formal economic analysis, the estimated return per each dollar of cost in the Perry program is about 17%, which is quite a bit higher than the standard rate of return on stock market equity, especially post 2008. Yes. So, I mean, it's very the Perry program and Avis Darian. They're enormous investments. They cost money for sure, but this rate of return is pretty good. This is like saying you put in each dollar into this program and you get $1.17 back in net present value terms. All right, so let me turn lastly to preventing the intergenerational transmission of poverty. I think this also is about investing in the early environment of children, and I think as Amartya Sen has said, one of the greatest tragedies of poverty is its intergenerational transmission, because children born into poverty enter adulthood without the basic capabilities to escape poverty, whether those capabilities include good health, having a decent education, having, being brought up with decent self-regulation and so forth. That's all well, but a huge challenge in anti-poverty programs is getting parents to invest in their children, make sure that they can enter adulthood in a level playing field, and giving them the chance to escape poverty. And the question is, how can they be motivated to do that? So, stepping back, quickly on the evolution of ideas in public discourse about poverty, I know, I'm sure you're probably preaching to an audience that already knows this, but as you know, the words, concepts like culture of poverty emanated from the work of anthropologists like Oscar Lewis, who in a study of a rural family in Mexico said there's a certain poverty culture which appears to condemn people into repeating the multi-generational cycle of poverty. And the way that he talked about it in his book, he said, it's a grinding poverty which kills people's motivation to invest in the future. And this culture, since it seems to be transmitted from one generation to the next, is characterized by a disdain for education, fatalism, alcoholism, and an inability to delay gratification. But the way that Sanchez talked about it was as a defense mechanism adopted by the poor in response to degraded circumstances. So when things seem so hopeless, then why should you try? And by trying, you're only going to disappoint and hurt yourself. That was the way he described it. Curiously, when we track the idea of the evolution of ideas, it's exactly the same concept used by someone on the opposite side of the political spectrum. That's the Harvard political scientist Edward Banfield, who, in The Unheavenly City, which is a study of the subculture in American inner cities, he said there's a culture there that is, lower class Americans have no fondness for work, no strong ties, easy acceptance of criminal behavior, no interest in school, and no future perspective. So he diagnosed the same thing, but he said that this is a culture which is going to cause people to be stuck that way, and therefore government programs like the War on Poverty will not succeed. Note the date in which he published it was probably the sort of the waning days of the War on Poverty, and that his prescription, his diagnosis that the nanny state is going to feed welfare dependency, and that's why policies won't work. So it seemed to us that these ideas, using the same language but arriving at dramatically different diagnoses, were deadlocked for decades until Santiago Levy came along and he was the former deputy minister of finance in Mexico, and he basically said, well, who cares about what the diagnosis is? Do we really care about whether the diagnosis of the pathologies of poverty is because poverty leads to bad behavior, as Oscar Lewis said, or is it because bad behavior leads to poverty, as Edward Banfield put it? And he said, what we really care about in a policy perspective is providing incentives for parents to invest in the human capital of children, thereby breaking the intergenerational transmission of poverty. And that's the second best buy. On a global scale, I think that I've seen very good evidence in the social determinants of health. And I've referred to the idea of conditional cash transfers, which Levy began in Mexico with a program called Progresa, later became Oportunidades. Basically, in this program, eligible families receive cash worth up to about 20% of household income if they meet certain conditions. That is, the parents can prove that their kids have been immunized, or they attend nutrition clinics, or come to antenatal visits if the women are pregnant. And to the credit of the Mexicans, they didn't just run the program and then claim success. They rigorously evaluated this in a randomized controlled trial involving over 500 rural villages. They flipped a coin. Some villages implemented this, others did not, and then they evaluated the results prospectively. And these results have been published in a series of papers in journals like The Lancet. They do demonstrate that if you put relevant conditions on your cash transfers, they lead to improved outcomes in the kids, reduced stunting, reduced obesity, and even better cognitive functioning. And the program now has been rolled out to 20 million Mexican families and then subsequently to an additional 30 low and middle income countries. I think this is a very, very interesting kind of program. I think it's interesting mainly because this is one of the few instances I know where an idea that was tried in a middle to low income country was attempted to be imported into a very rich country, namely the United States. And I think in 2007, Mayor Bloomberg decided that the Mexican progressive was so promising, opportunity was so promising, that he decided to try it out in his own backyard. And he launched it, much of it with his own pocket money. I think he put in about 20 million of his own funds. It was very much modeled on Mexico's Oportunidades. He also decided to evaluate using a randomized trial design. So he randomized about 11,000 children, and in the kind of structured incentives that that are featured in the program include. This is just a sample of some of the conditions. For example, if the parents who were randomized to this could show that their children were attending 95% of school days, well, then you get a little cash payment. $50 a month, for example, if your child is in high school. If you score at a proficient level on the annual math test, you get $300 per test. If your kid graduates from high school, it's a $400 bonus. If you attend a parent-teacher conference, it's $25 a pop. Then they had some health incentives, which include maintaining insurance status for children, scaled differently depending on whether it was private or public insurance. And whether you can prove that each family member received an annual medical checkup or dental checkup. So, as I said, it's a randomized trial. They have published the interim findings in the first 2 years of the program. The average family enrolled in the program earned rewards averaging about $6,000, which is quite a hefty income supplement. Unfortunately, Mayor Bloomberg decided to discontinue the program after 3 years because of what he called the expense and the disappointing results. I think I'm going to show quickly some of the results. I think it was mainly the expense, actually, which is the reason why it was discontinued. As I mentioned earlier, it launched in 2007, which unfortunately was a year before the economic crisis, and then in 2008, I guess his personal wealth got hammered, and he couldn't, afford to keep paying 20 million of his own money into the program. If we look at the results, they're mixed bag, but for health outcomes, I find them quite promising. Education didn't show very much. It didn't improve the school outcomes for middle and elementary school kids, and one reason is that attendance rates were already high in the New York neighborhoods where the experiment was done, so that there was a kind of a ceiling effect which they couldn't break through. And although the program did boost educational achievement among high school kids, they did so mainly among kids who were already doing quite well before they entered the program. So it kind of it encouraged kids to do even better who were already doing quite well. So education, I think they needed to restructure the incentives in a different way to achieve better results. But the number of health outcomes, which I thought were moved in a very interesting direction, there's a significant difference in the reduction in the period in which children had no health insurance coverage, reduction in the percentage of families that use hospital ER for routine care, an increase in the proportion who say their health is excellent, and an increase in the proportion who have dental visits in the past year. I mean, these are modest effects depending on the outcome that was being considered, but nonetheless, it seems to me that this is one direction in which policy might try to break that intergenerational transmission of poverty. I think we don't. I'm not trying to push to suggest that conditional cash transfers are an unmitigated panacea for all of problems in poverty and public health. We do have some questions that we need to answer yet. Most importantly, among them is whether doing so can stifle intrinsic motivation. This is the argument that why should we pay parents to do what most parents are supposed to be doing for their children anyway? That's fair enough. I guess the counterfactual is if you just hand out cash, without any strings attached, then they wouldn't be doing this either, presumably. I think the most important thing is, if it stifles motivation, the real test is, are these beneficial parental behaviors sustained beyond the period of receiving cash? That's what we'd really like to know. Once you start them on a train of behavior where they're starting to make investments that are good for their children, can they be sustained? And we have an opportunity to study this because, as I said, the New York program ended in August of 2010, and yet the follow-up of individuals is continuing, and we shall know the final report, which is due in next year. So, I could have emphasized many kinds of social determinants interventions, ranging from improving workplace, climate and organization, to changing the income distribution, to boosting social capital. Perhaps we have time to discuss some of these in the question and answer. But if you were to press me on where are the two things, for which you have the greatest evidence that I think these things are ready to be rolled out into prime time, I would have emphasized these two interventions. Anyway, I hope this gives a kind of flavor of where social epidemiologists are going with respect to what to do about the social determinants of health. Thank you very much. I'm very happy to take questions and comments.
Thank you. Before you do, a small token, so you
no reason. Thank you. Thank you so much. Right.
Do you have time for a few questions?
Yes. Yeah. Yes.
I have a question about conditional cash transfer.
Yeah.
Conditional cash transfer programs.
Yes.
So when you were talking about Mexico, you were saying that the randomization was across communities.
Yes.
I don't think you said, and I don't know the answer to how the randomization was done in New York.
Yeah.
But if it wasn't done by, say, neighborhood, I'm curious as to your reaction to what difference there might be if you if you're changing, trying to change incentives within an entire community or within a neighborhood or within a social group, as opposed to individuals within a much broader
that's
community.
Very interesting idea. I think if we had our druthers, actually the reason why community randomization, cluster randomization at the community occurs is because often we're worried about spillover effects. That is, if you take families and randomize them within a community, then the so-called control group, which didn't receive the randomization, might start learning from those that did and change their behavior and muck up your results. That's why we often do cluster randomization to try to minimize those kinds of spillover. So it's for a methodological reason that we often do it. Now, in the Mexico case, I believe that that cluster randomization came about more or less because of political exigencies. I think some governors were keen to do it in the whole state, and others were very slow on the uptake, and they had a hard time getting the governors of certain states to agree to do it within the communities. They said, I just want all the villages to get it or none, and those that don't get it, I just want them rolled out afterwards. So the way that Gary King and Julio Frank described it, I think it was a political decision to do it that way. Mayor Bloomberg's was randomized not by neighborhood but by families. So the families received a kind of went through a lottery, and if they came up heads, they were enrolled in the program. If it was tails, they just went back to the status quo and whatever public assistance they were receiving. And I think we have to be careful about how to interpret the results based on the possibility that there is spillover effects, that might influence the results that you observe. But that would be the main thing I would be thinking about. Yeah. Did you have something else in mind?
No, I was wondering, want there to be spillover, not from a methodological standpoint.
Yes.
If you're trying to produce long-standing
Yes.
change,
Yes.
it's going to be easier to do
Yeah.
if everybody is doing it.
Yes. Oh, I see. Yes. Yeah. So you're pointing to the importance of change in norms and how norms can drive behavior change. I think that's very important. In this case, the way that it's being thought about is you incentivize the individual parents to start doing this. And over and above that, there may be these spillover effects through community norms. That would be like an added benefit of these programs on parental behavior and child health. Yeah, I see what you're saying. Yes?
I know you said earlier that you're not so familiar with the human rights framework.
No, I
wanted to just ask, I guess, and just get your reaction to the question about whether or not, of course, human rights would be a way for lawyers, for legal folks to apprehend, to be able to get involved in this.
Yes.
And you talked about the study of charity,
yes.
causing people to give or not give as much based on how they're approached.
Yes.
I guess I was thinking whether the human rights framing device is a way of actually creating more concern in people about this than they might have otherwise.
Yes.
There's a lot of dating
Yeah.
who cares, but framing it as a human rights issue.
Yes.
Aside from
appealing to notions of morality and such.
right.
Yes.
Well, and also that it's a way of appealing on an individual basis, but without that individual story in a way, right? Human rights is something that is a very individual situation, even though what you're providing is something that's affecting the large population.
Yes.
So I guess I was just wondering if that was a way in which that framework might connect with this,
yes.
As a way to try to motivate people.
Yes. Yeah, I never thought of it that way. I think that would be a promising way to proceed, and how do we communicate the importance of this material? I think in the kind of the emerging behavioral economics literature, we make a distinction between the reasoning system versus the sort of perceptual, intuitive system 1 and system 2. And I think in that jargon appeals to the identifiable victim or beneficiary is a very strong system 1 appeal, whereas all kinds of reasoning based upon higher order consideration of ethics and morality are sort of system 2 kinds of appeals. They can both coexist, and they have they kind of influence each other in a way. But I was trying to describe descriptively what is it that's going on in people's minds when they respond much more readily and vividly to these personal scenarios than they do to the statistics. But you're right. I think appealing to ethics may mobilize some of these system 1 type things like emotion, sense of fairness, justice, and so forth. I think it's a very promising approach. Yes.
Yeah, I wonder to what extent your examples actually really speak to the social determinants of health, because they strike me as quite individualistic. They're focused on individual behaviors.
Yes.
Not where I would take the social determinants approach. I guess I'm also coming from a human rights approach where you look at the state's obligations, where you look at systems. So in a way, with early education, rather than educating some students, sort of educating, producing a superhuman or something, you can think about universal pre-K.
Yes.
Or in terms of poverty transfers, you would think about, well, what if there was no poverty, if everybody got a living wage? So it's kind of like this looking at behaviors of individuals and families strikes me as not fully really implementing the structural elements of social determinants.
Yeah, that's a very good point, actually. So they tend to. There's a sort of a bit of a slippage there, I mean, well, universal pre-K is, or universal early education investment, I would totally agree with that. I'm not suggesting that this should be an individualized policy where, we encourage some parents to do this. I think society should invest in universal enriched education among the sort of investments that we could be making. That's where I would put my money. In terms of the conditional cash transfer, I mean, it is a sort of a societal policy lever, but that's right. We're trying to influence individual change. I mean, if we had our druthers, absolutely, I would like to eliminate poverty. I would like to change the income distribution, and I would like to, create a utopia. It's very true, and I couldn't disagree with that.
But if we just look at schools, I mean,
Yeah.
I just feel from a human rights perspective, there's so much discrimination in schools.
Yes.
The way the children are treated in schools,
Yes.
Yeah. I feel like, from an ethical and human rights perspective, that's where you would intervene in order to create some form of equity, rather than focusing on sort of the individual behaviors. So you would focus on the anti-discrimination approach. So then on
I see.
How do you up individual performance?
Yeah. Actually, no, but I'm curious why you say that, is because is there, what's the basis in which we can say that that's the where we should be making the investment? I think if you have data to show that, I think that's what I'm curious to see, because I'm trying to argue agnostically based on what we can say on the available evidence. And a lot of the evidence does, I couch it in a way is if you had to spend $1 on educational investment, where would you spend it? And much of the discussion is about improving, making colleges, more affordable, opening up, more sort of higher levels of education. Whereas most of the action, in terms of educational outcomes, whether they be labor market success or health outcomes, they really point to the importance of doing stuff early. So if I think to me it's partly an empirical question of, do we have good comparative data to inform where we should be making the investments. And if there's data, if there is evidence that discrimination is the prime issue, I think certainly we should go for that.
I think we only have time for one more question.
Yeah, sure. So, well, even two more. Go ahead.
Two more.
Yes. Please. Yeah.
Hi, my name is Sabrina. I'm a human rights attorney here in Boston.
Yeah.
And it's funny. I'm wondering if there is a way to bridge what Anya was saying and what your research suggests.
Yeah.
Hello, can everyone hear me? All right, so forgive me, I'm thinking through this thought. I think it could be possible, like your idea of attaching, I guess, cash,
yes.
To benefit people who need early intervention, for example. If we did apply that in a health context, in the sense of, when the government does provide health care for people who need it, and attaching cash incentives for people to either, access some type of early benefit program so that, they do have better health outcomes in the future. I think that would be a great model, and I don't know if it's possible for us to implement it as a society, but I wonder if people here in the room who do work with either insurance companies or on behalf of government programs, if that's a way we can vouch for that to be done.
There's lots of programs like that. So it's not just paying parents to invest in their kids. There are lots of demonstration programs that pay people to stop smoking, pay people to turn up to screening programs. There's even an experiment in UK schools where they paid kids a quarter to eat their vegetables. It works. I don't know who's going to fund that, but incentives do work. And I'm an empiricist to the extent that I think if you can afford to do it and you can show me that it's cost effective, then let's do it. Yes. Yes. Yeah.
I'm from Mexico, and
I
do the criminalized program. Perhaps we can say to New York, when they try to put the program, that medication, I'm sure that in Mexico will not function either. Not because we have a high educational standard, but they just say 95% of the kids go to school already. Not because of that, but grassroots level at school.
Oh, I see. Yes,
Even though
that's right. Yes, yeah. No, that's a very good point. I should have put down on this, the conditions for successful conditional cash transfer. No. I know. I should have put down among the conditions for a conditional cash transfer program is that you have to have the functioning infrastructure to put the incentives, because there's no good sending parents, making sure that parents send their kids to good schools if they don't exist, So you do need that.
Why Mexico, if opportunities has been so good, why Mexico hasn't had this for education?
Ah,
right. And I also think because
of
the poor condition of the people that receive opportunidades, even though it has a political thing, I think that immediately the benefits that so immediately in opportunidades to receive cash, and also something called canasta básica, that is kind of the basics of food.
Yes.
So, that day you receive every morning. So that's very good and very important to have it.
Yes.
But in this sense, I think, about Seguro Popular. And what do you think about when they were discussing about asking for the people to pay like a very small quote of money?
Oh, yes. Yeah.
So they feel like they have an incentive, a positive incentive to go to the medical doctor every time they need. At the end, this discussion is said because it was more expensive for the government to implement and ask for the money and make the people go. What do you think about this?
I'm not so familiar with the intervention Seguro Popular. So actually, I wasn't aware that they put a charge like that to incentivize people to go.
They quit with that discussion. It wasn't enough, so they should pay a little bit.
Really? I've heard that you should of the idea of putting a charge in order to disincentivize unnecessary use, for example, or in the sort of social marketing literature, if you're going to distribute free malaria bed nets, maybe you should charge them a nominal sum so that they take care of it, as opposed to something given free, which has less value in the mind of the recipient. But I've not heard that reasoning for Seguro Popular. To me, that sounds like a kind of a somewhat regressive way of arguing putting a user charge on a patient group, because I don't know whether there's evidence that really does increase the rates of attendance. I would guess that it has the opposite effect, actually. So that's a different program, though.
So thank you so much, Dr. Swarovski, and all of our